Good evening, everyone. Welcome to the Foxy Young Talent Promotion Committee in collaboration with the Organization for Rare Diseases India. So today's topic is about genetic and rare diseases. And I think as all obstetricians and gynecologists, it's important to understand where our role comes to play in this. Today, we have a variety of speakers and well-renowned speakers who are going to be giving us an idea and an in-depth analysis of what we need to perform during our entire obstetric career of our mothers. So without taking too much time, I would like to begin by introducing our chief guest. Firstly, I would like to just say thank you, Dr. Niharika, for giving Shaila, me, Aarti, an opportunity. I think I missed out on one name, but thank you for giving us an opportunity to be a part of this program. I also want to thank our Foxy president and our chief guest for today, Dr. Shanta Kumari, ma'am. She is the president of Foxy. May I please have a CV? Even though she needs no introduction, ma'am is an FRCOG honoris causa UK as well as the FRCPI from the Royal College of Physicians and of Ireland. She has initiated DHERA 2016, a social medical campaign to eliminate violence against India. She has delivered many orations, and more recently, ma'am has been elected unopposed as the treasurer of FIGO. Do we have Shanta, ma'am? I think she was caught up in an emergency. Aarti, is
ma'am is going to join at around 5:30.
So I think we'll request ma'am to say her few words in some time. May I please introduce our guest of honors, Dr. Basab Mukherjee and Dr. Madhuri Patel. May I have Dr. Basab's CV slide, please?
I think Dr. Madhuri should go first, Rohan. Dr. Madhuri.
Yeah. So Dr. Madhuri Patel, ma'am, she's our Secretary General of Foxy. She's also been the Joint Secretary of Foxy in 2009, a committee member of FIGO Preterm Birth, and Associate Editor of Jogi, Honorary Clinical Associate of Navroji Vaidya Hospital, Parel, Honorary Consultant at Police Hospital, St. Elizabeth Hospital, former Professor and HOD at MGMH, Mumbai.
Thank you, Rohan.
More than anything else, I must say that Madhuri ma'am is a mentor. She has always guided me through and through my entire MOGS and Foxy career. And ma'am is always available. Whenever you call her, she'll always answer and answer you with a smile. So ma'am, welcome to the program, and we'd love to hear a few words from you.
Thank you, Rohan, for your kind and warm words. And Basab, thank you very much for giving me this, opportunity. And I must also thank Niharika. Respected our President, Dr. Shanta Kumari, today's chief guest, Vice President, guest of honor, Dr. Basab Mukherjee and Archana Verma. Then our youngest committee chair, Dr. Niharika of the Young Committee, and all the, of course, I cannot forget Dr. Narendra Malhotra sir and Dr. Rishma Pai, our past president, and today's all the, if I say Dr. Dipanjan Datta, Dr. Parikshit, Dr. Madhulika, Dr. Rohan, Dr. Keshav, Dr. Ratnapuri, Dr. Aarti, Dr. Snehla, Dr. Selva Priya, Dr. Shrutika, Dr. Sheetal, Dr. Apurva, Dr. Veronica, Dr. Mohit, Dr. Anju, and all my dear friends. Very good evening to all of you. At the outset, I would like to thank the organizing team for giving me this opportunity. And all of us are aware that Foxy is the one of the largest professional organization of the world, with 263 member bodies and 38,000 plus committed members to women's health. We have 28 committees now and the 28 committee chairperson. And all the committee chairs are doing excellent work. And I must say about Niharika, I must appreciate and acknowledge Niharika. As I mentioned there, we are the youngest and plus of the committee of the young talented promotion, So she has a lots of innovation, innovation ideas, and she believes in implementation. So she is implementing, and if you see her each webinar, they are on the different topic, they are unique. And I really, really admire you for that. And today's topic is also genetic and rare diseases, very, very, apt a webinar. If you see, we have reduced the maternal mortality rate to 103 per 70,000, 103 per 100,000 live birth today, and we are marching towards achieving our sustainable development goal of reduction in maternal mortality by less than 70 per 100,000 live birth by 2030. But now this today's topic is also very, very important, that how in utero and before the embryo transfer, we can diagnose or we can prevent the genetic diseases and rare diseases. So we have, all of you are aware that we are having dual marker test, anti-test, first trimester, second trimester, quadruple marker, then malformation level 2 scan, then we have NIPT now. Only NIPT problem is the best test, but it is very, very expensive. So I think this NIPT is more or less restricted to the IVF specialist when the patient conceives. And we want this NIPT should go to everybody. And of course, depending upon that, we have invasive tests like Korean millets biopsy, amniocentesis, etc. And PGT and NICS, that Rohan and who is one other person are going to debate on that. And I would really like to hear about it. And we have all the tests. So whole idea is that we should do within 24 weeks of pregnancy, diagnose and give the patient the choice whether to terminate or continue with the pregnancy. But I will also tell all our delicate friends, our members, that you should remain within the framework. Don't go, whatever X says, don't go beyond that. If 100 things you are successful, but 101 you are not successful, nobody is there to protect you. So at the same time, we have to remain within the act. And then we have galaxy of speakers, chairperson, expert, moderators, panelists. They are going to highlight on this topic, and which is really going to help us in day-to-day practice to benefit our women and the children. And at the end, I would like to mention, I always enjoy this quote by Benjamin Franklin, that investment in the knowledge gives the best interest. So therefore, we all have to, invest, in our updating the knowledge. And we should give healthy population, healthy generation to not only parent society, but also our nation. And we should see with all these tests, the healthy, generation in future. And I really thank the organizer for giving me this opportunity.
Thank you so much, ma'am. It's always a pleasure to hear such encouraging words from you. You've always been a big supporter of the youth, and we can always see you always achieving hard to ensure that all the youth of Foxy are getting promoted and always being supported by the seniors. So thank you so much, ma'am, for all your kindness.
Rohan, thank you. But I would like to also add that if I see the speaker, they are so young and enthusiastic, and I really congratulate all of you for the same.
Thank you so much, ma'am. Our next guest of honor is Dr. Basab Mukherjee, sir. I think sir also needs absolutely no introduction. He's the Vice President of Foxy, and he is
no introduction. You've already said, Rohan, and then don't keep on.
So just one thing, sir is the organizing secretary of the Kolkata AICOG 2023, and so we're really looking forward to being there and seeing you in person.
Absolutely, Rohan. I'm sure we'll see ourselves in person much before that and many other places too. But just coming to the topic, two things. I think I want to have to echo Dr. Madhuri, what she said about Niharika. Really wonderful work tenure as a committee, the what little bit which I managed to see as a vice president. Really wonderful work, Niharika, always thinking out of the box, bringing in different organizations, bringing in different ways of making things interesting, which is really remarkable, adorable. And I like to copy some of the things which you have done, because I'll try to do some in the AICOG and maybe later in different other posts in my Foxy tenure. So wonderful work, great going, Niharika. And this is some society which we never knew of, Organization for Rare Diseases in India. So whenever you read in your pathology genetics, there's something in the lower part of the page which you never read. It's either in asterisk or something very small. And that's something where the diseases come in, and that's so interesting. Yet, so it usually limits itself to the MCQs or the quizzes, where in the quiz or you have a picture up of an image of something, or maybe something in an MCQ format. So that's all we know about rare diseases, but I'm sure we'll be learning much more. Dr. Dipanjana is here. She's a geneticist from Calcutta. We know her well, and I hope all of us would like to learn from all of the people and get ourselves more educated on rare diseases, something which we don't discuss most often, and it's something which we don't talk about every day. So it's new, it's novel, and I'm sure we'll all be educated and leave this place wiser at the end of this. Thank you, Niharika, for inviting me, and all the best to the academia that's going ahead.
Thank you so much, sir. And I think, sir, Niharika always says that without proper guidance, we're unable to do what we can. So thank you so much, sir, for always guiding us as well for carrying out these programs. Even whenever I call up Niharika always says, just cross-check with Basab sir, because he'll give you the right advice to go ahead. So thank you so much, sir. Now we come to our program. But before we start off any program, I would like to ask Niharika. And Niharika, can you just introduce Archana ma'am in 2 words as well?
Yes. So we also have Archana Verma ma'am here, who is the Vice President of Foxy, and she's also the Founder President of West UP ISOPUB. And I'm so glad, Archana ma'am, you could make it for today's program. And we would also like to have your blessings for today's program.
Niharika, I must say that you have that strength, and you and Rohan are doing wonderful work under guidance of Dr. Narendra Malhotra. And I must say only in one line, it is really good to dare to handle the rare. And you know, the genetics is something, it is goes beyond that mind, and you never think of, but you are always afraid of, especially the patient. So it is always good to talk about. And my blessings are always with you, always. You are doing wonderful work. Thank you.
Thank you so much, ma'am. And thank you, Rohan. Let's go ahead.
Yeah. So just before we begin the program, we should always begin with a prayer and an auspicious start. So just can I request you to please play the prayer and the lamp lighting as well?
Yes.
आरोग्यं धनसम्पदः शत्रुबुद्धि विनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं.
Thank you so much. May I now introduce Dr. Arti. She is a senior resident, AIMS, New Delhi, MBBS gold medalist, MD PGI Chandigarh silver medal, and ICOG fellow in gynecology.
Thank you, Dr. Rohan.
All right, over to you so we can start. Thank you.
Can we have the next slide, please? So as Rohan has rightly introduced all the panel, all the chief guests and the guests of honor, let us go ahead with our talk without wasting much time. May I now invite our chairperson, Dr. Parikshit Tank, sir. Sir is a consultant with the Ashwini Maternity Hospital in Mumbai, and he's a very senior endoscopist and has a great IVF center with him. And may I now invite sir to introduce our first speaker, and we go ahead with the sessions. Dr. Parikshit Tank, sir.
I can't see
Niharika,
him.
I think sir had just texted that he was stuck in an emergency. He was going to try and log in from his phone, but I think he's not yet logged in. Niharika, why don't you...
I'll do that, yeah.
Please.
Chalo, let's go ahead and let me welcome you, Dr. Dipanjana Datta, today for our first speaker for today's session, who is a PhD and PDF from USA. She is done her PhD from Indian Institute of Chennai Biology, Kolkata, in human genetics, and she's also a postdoctoral fellow in Oregon State Health University and Virginia Commonwealth University. Today we are going to be learning about rare diseases, and that our aim with YTP is to bring in different topics and spreading knowledge, and that's why we have the Organization of Rare Diseases with us. And over to you, Dr. Dipanjana, to take this ahead.
Thank you so much for the introduction. At the very outset, I would like to thank the Foxy YTP, ORDI, and Mr. Prasanna Shirol for actually having me here. And without like wasting much time, I'll just share my screen and start. I hope my screen is visible.
Yep.
Yes. Yes.
So I will be giving an overview on rare disease. I've been allotted time of about 12 minutes. It's a bit less, but then I'll just try to fix in everything I can within this time. So when we talk about rare diseases, it's of course, as the name suggests, it is something that we don't come across clinic very often. These are diseases which might mimic normal situations or normal manifestations, but they are something more complicated. And hence the problem is the number is so less that we don't really have a natural history. We don't understand it because of the less number. Hence, we have very limited knowledge about the pathogenicity. And also because they are so complicated yet so less, there are very less targeted treatments. So all of this makes this a black box with a very complicated names at certain times and with overlapping clinical manifestations, which confuses diagnostics and sometimes even evasive. So with that introduction, if we just say what rare diseases comprises of, it can be an infectious disease, it can be an immunological disease, but 80% majority of all rare diseases are genetic in nature. Now, with India having 1.3 billion people and 4,500 ethnic groups with 300 languages, what is happening is that we know that there are about worldwide, there are 7,000 such rare diseases, but India has documented only 450. We don't know whether that is because of less diagnosis or whether we actually don't have it. Now, to understand the actual, when we call it as rare, what do we mean? What are the numbers we are looking at? Each country has its own definition of rare diseases. How does this definition come into play? Is that maybe there was a large population, but due to some reason, maybe decrease in population migration, isolation, or even inbreeding or marrying inside communities, a certain number of people got isolated and started breeding amongst themselves, which started accumulating the negative genetic traits. Now, when they get married, the chances of a rare disorder increases. Now, this paper, which was published a bit earlier, but still holds true in 2019, this was published. It just states that because India has multiple endogamous communities, like you marry inside communities, and we have a prevalent customs of consanguinity in some places. These definitely play a huge role in accumulation of genetic traits, contributing to high prevalence of recessive alleles, which translates into genetic diseases, including rare genetic disorders. Now, WHO had made a comment way back saying that India is a melting pot, and there are chances of the chances of having a non-communicable disorder is more than having a communicable disorder as we progress. And that, with the incidence of diagnosis increasing, sort of holds true. So if we look at this, the Western world, they have right now collated data from Uroids, Nord, and what they have done is they have come across incidents for each of the rare diseases which are known. And in doing so, Orphanet documents about 6172 unique rare diseases, 70% of which are genetic, and of this 70% are of pediatric onset. Now, the way they have calculated is called a point prevalence, where basically for each of the cases or families, for each of these unique rare disorders noted versus the global population, they have come up with the statistics. And what their statistics suggest is that 3.5 to 5.9% of the whole world population is sort of affected with a rare disease, which makes the number 263 to 446 million people. And that is not a less number, and that is actually a huge number in totality. Now, ORDI in 2015 had proposed that the rare diseases in India, the incidence, as you can understand, because this is a population specific thing, the incidence will vary, and ORDI had proposed this as 1 in 5,000, which means that 1 in 20 Indians can be affected by rare disorders, and that means about 70 million people in India are actually suffering from rare diseases. In 2017, ICMR came up with a definition of 1 in 2,500 from the statistics that was available at that time. That translated into our orphan drug regulations and orphan drug definitions as well. But till date, because we don't actually have a very functional registry, we actually don't know what exactly is the incidence. If we just look at the cause of death, then about 30% of neonatal deaths occur below the age of 5 years. And if you look at these would be due to congenital birth defects, diarrhea, cardiovascular diseases, kidney diseases, and some neonatal disorders. Now, there are reports about 64.4 per thousand births are having certain kind of birth defects. What is interesting is this point that 70% could have been prevented or known from before, and there can be certain actions taken that could be life-saving or that can significantly reduce the disability. So there is a choice that could have been taken if there is a proper screening. The other picture, which is also very important, is the inheritance patterns. We know that there are various inheritance patterns, and if it is actually coming from, if it is hereditary, then there is a chance of another affected child. You have one affected child and there is the chance of recurrence, and that would make the situation worse. Hence, diagnosis is very important, but that is where rare disease is elusive. So here I share the story of Nidhi. Nidhi is Mr. Prasanna Shirol, who is the founder of Organization of Rare Diseases India's president. So Nidhi was a child who was born out of a non-consanguineous marriage, and she was perfectly okay since birth, but she suffered from bouts of respiratory problem, which gradually progressed to the extent that she had to be on a wheelchair. After a diagnostic odyssey of 7 years, 45 consultants, and myriad tests, Nidhi was diagnosed with Pompe's disorders. And as this actually laid the foundation of Organization of Rare Disease in India, what remains is that what is important in this slide is that if you would have looked at Nidhi's family history, then one of his paternal uncles actually succumbed at a very early age, below 10 years, and with a similar history. So you can understand that how much it is important to take the family history when you have a couple in your clinic, and maybe we should not look at it just as recurrent respiratory infections, and we should look at it as a whole. That might give a better suspicion to diagnose diseases. And this story of Nidhi and Mr. Prasanna Shirol's family is perhaps the story of every rare disease family, and they have the same experience to share. Now, how can we sort of, be better in doing this is first start with screening. Obviously, there are certain screening, aneuploidy screenings, which are in place. And there are, if you do the scans, there are certain risks that come in, and you can do the aneuploidy screenings. But the aneuploidy screenings might not be the be at all. Like in this case, where at 12 weeks, it was presented with increased NT, absent nasal bone, DV not really visualized, the quadruple marker screen positive, but it came as CMA negative. But at 19 weeks, it came up with additional congenital abnormalities. And when we look at the fetus, we see that obviously there is a lot to look at the fetus. And if we actually do a correct kind of phenotyping, we can see that depending on what we are seeing, rhizomelia, mesomelia, rhizomesomelia, whether it's bowing or it is straight, we can actually go for a single gene disorders. Maybe it would be a panel or it would be a single gene disorder, depending on what we are looking at. And here, one single test was probably not a blanket answer at all. Also, the degree of suspicion. So in the previous cases, probably in the fetus, you had something which came up in the USG. In this case, we had a fetus which was obviously on the face, like had certain kind of congenital abnormalities. But sometimes a rare disease family can present like this. You can see this couple had recurrent pregnancy losses. They had two recurrent pregnancy loss. One was a female fetus which was presented at 18 weeks with echogenic stomach valve, mild bilateral renal pelvicitis, and congenital heart problems, while fetus 2 was a male fetus at 21 weeks with lemon-shaped skull, hydronephrosis, and amniotic band syndrome. Now, when we followed the ESHRE guidelines and actually looked at the whole, assessed the woman, we also found that she had a septate uterus. But what was most striking to me, though they didn't have any kind of significant that kind of a family history, what was most striking to me was how this man looked. This man is a businessman. He has achieved everything. There is nothing on the face. He was sitting, but my eyes was actually drawn to the dysmorphisms, which I was seeing. He had this very heavy hooded eyes. His ears were low set, the nose, this actually, and the webbing in behind his back. He was very typical of an attenuated adult Noonan syndrome. So when I chased this, and what we found was we did find a mutation which was linked to this, and that might have explained his first miscarriage, not the second one, but his first miscarriage. And this couple then had a 50% chance of passing it over, and they now could be given certain reproductive choices as to whether they would like to go for a prenatal diagnosis or they would want to go for a pre-implantation diagnosis. Now hence taking the history of the family, if there is any kind of such histories like we spoke about Mr. Prashanna Chirol's family, or if there is a consanguineous relationship, ACMG now recommends a carrier screening, which can also help to reduce the chances of an affected child. Hence, the way forward would be whenever anyone comes to your clinic, a deep phenotyping, a family history. If there's any prior genetic tests, you can refer them. If there is something significant, you can refer them to somebody who practices genetics, and there can be a genetic testing, and along with the clinical interpretation, there might be helpful for that particular family. Why this needs to be done? Because, as I said, most of these would be genetic disorders, and most of them, the management is, if we have a child who is affected, would be symptomatic. We don't have a medication or anything that can actually protect in most of the cases. Or there are therapies available, which can be a bone marrow transplant or any kind of organ transplant like liver, kidney, heart. But there are certain enzyme replacement therapies available. There is diet restrictions or diet modifications that are available. And very recently, we do have DNA modifying therapies. We have all heard about SMA. We are hearing about DMD. But what is to be known is that these are only available through Compassionate Action Program and crowdfunding. ORDI has these setups where we are able to achieve these for some people, but still the prices of these drugs are too high. They are not as high. They are so high that the test costs would be lower than that, and hence it's better to do the test. And every family, even if they are not going through taking the drugs, or they are not being able to get the drugs, still they have to bear the cost of the child, because there are number of follow-ups and number of managements that are happening. So prevention is better than cure. So screen your patients, try to diagnose. If we can go for a prenatal diagnosis, give them the option of amniocentesis or CVS. Like for this case, there was a previous child where they had detected it biochemically, but there was no genetic testing done. We went ahead, did the genetic testing prenatally. We detected that this fetus was also affected. And so, though it is a sad thing for the family, but still they are sort of given a respite from again losing a child who is born. In such cases, you can discuss other reproductive choices like a donor or pre-implantation genetic testings, which can actually help this family. The most important thing is the awareness. Unless we are aware, unless we have the disease suspicion, there will not be a screening, will not be a diagnosis. If we look at the Western world, the amount of publication just in rare diseases is 310, 685 till date. But if you look at India, the same is 12,835. It's not that we don't have cases here. We have more cases here, but maybe we look at it we don't publish, we don't look at it in the way we should be looking at it. And hence we are lacking in the awareness, we are lacking in collaborations, and this should be some cornerstone where we should turn and we should go ahead with it. So at present, the key action areas is obviously there's lack of awareness there among patients, medical fraternities, there's late diagnosis, the cost of the medications are huge. We do have lacking of the regulatory network, the lack of the clinical research, and also unavailability of the national level patient registry. But screening, proper deep phenotyping screening diagnosis can actually shift the paradigm from like the historical patients to more of the pre-symptomatic patients, where they can have a proper reproductive choice, and you can actually go ahead and reduce the burden in India. So with this, I would like to end my talk. I'm sorry if I rushed through, but that's what it is. Thank you.
Thank you so much, Dipanjana. And I think with the Foxy YTP committee, we also aim to bring an awareness. Like today, we did this program with ORDI to make people aware that there is an organization which is working for rare diseases in India, and we have help wherever we can get it from. And if we have a case of rare diseases, we can always contact you guys and understand it better. Genetic burden in India is increasing, and we have seen a rising trend of genetic diseases which are coming up, and there are rare diseases, but India is poor in documentation. And that's one thing which I want my young doctors to be strong at, that we have to start documenting every rare disease which we face. And I think that will make a huge difference. So thank you, Dipanjana, for being here today with us. Thank you.
Sorry,
I think
I'm coming in
Niharika
late.
sir is there. Yeah,
Yeah,
Parikshit sir
I'm
is
coming
there.
in
Yeah.
late. I'm so sorry to join the meeting a little later than what I was scheduled to. But Dr. Dipanjana, and really it was a genuinely learning session for me. So thank you very much, and congratulations, Niharika, Rohan. You guys are doing a great job, and this is a very important kind of a program that you've organized, because we rarely talk about rare diseases. So I think thanks for having this program and making people more aware that these resources exist. Thanks.
Thank you so much, sir. And we'll have our next session today. And we have a slight change in the next session. Dr. Anju will be speaking second. And Parikshit sir, if you're here, you can introduce our next speaker. Sir, please unmute, sir.
Sorry, my pleasure to introduce Dr. Anju Shukla, who's a pediatrician with a specialization in medical genetics. She's a professor in the Department of Medical Genetics at the Kasturba Medical College, Manipal, one of the most acclaimed centers for higher education in medicine. And she holds research interest in discovery of novel phenotypes and underlying genetic mechanisms of Mendelian disorders. I think, these things are so uncommon for obstetricians and gynecologists like you and me that we strain to even read CVs of this nature. So, Dr. Shukla, welcome, and the stage is all yours.
Thank you so much, Dr. Tank. And sorry for giving such a complicated CV. I should have looked. Yeah. So I'll just share my slide. Are the slides visible?
Yes, ma'am.
Yes, please go ahead.
Thank you very much. I thank Foxy, Dr. Niharika, Dr. Rohan, and everybody present here. A very good evening to all of you. So I know that the topic is quite complicated and I just have few minutes, but I will just try to make it as simple as possible for everybody. So this is just an overview about what genetic disorders are and how they are caused. So we know that all our genetic material, this is actually a linear molecule, which we call as DNA. And this DNA is coiled and supercoiled several times unless we see these complex structures, which are called as chromosomes. So each of us has 23 pairs of chromosome, or overall 46 chromosomes. So there are several levels at which the defects can occur. So first level is genomic disorders, where we see that there can be polyploidies like triploidy, or there can be aneuploidies like monosomy, trisomy, etc. Then we can see that there can be some gains or losses, gross gains or losses in the chromosome material, which we call as chromosomal disorder. Then there are some submicroscopic defects, which we call as microdeletion or microduplication syndromes. And then some of these defects can lie at the level of genes. So these 23 pairs of chromosome or 46 chromosome, they actually have 19 to 20,000 protein coding genes. And any change in these genes can again lead to a genetic disorder, and we call them as single gene disorders or monogenic disorders. And then there are some more complex phenomena, which I will not going into, like triplet repeat disorders or mitochondrial disorders, something beyond the DNA sequence called as epigenetic, and sometimes there is an interplay of genetics and environment, which we call as complex disorders. So I think this is what most of you will be familiar with. These are the trisomies, trisomy 21 and trisomy 18, and also trisomy 13, which are like bond trisomies. We know that if there is a monosomy or there is one less chromosome, so if there are 45 chromosomes and which involves any one of the chromosome other than the sex chromosome, they are not tolerated because each chromosome is going to have several genes in it. And when one chromosome is lost, that means there is loss of so many genes, and that's usually not tolerated and is not compatible with life. On the other hand, if there's an extra dosage, like here in the case of trisomies, you can see there is an extra chromosome 21 for trisomy 21 or Down syndrome. And here you have an extra chromosome 18. This sometimes is tolerated. So the babies are going to have a lot of mental and physical problems, a lot of malformations, but they may be light born. So the next set of defect is at the level of a chromosome, which can result into some parts missing from the chromosome. Like we can see here that the very distal end of the 5th chromosome, the short arm of the chromosome is missing, or 5p minus syndrome. And then when we see here, we can see there is something extra. This is the normal to chromosome number 2, and we can see some extra material here because there's a duplication of some part of chromosome number 2 here, or a 2p duplication syndrome. So these abnormalities were quite deadly, picked up by the conventional testing that we call as Karo typing. And then we have some defects which are much smaller than that, and then they're not amenable to be picked up by routine Karo typing, and they are called as microdeletion or microduplication syndrome. So I hope you would have heard about Dijot syndrome or 22q11 or velocardiofacial syndrome, Williams syndrome. So these are recurrent microdeletion syndromes. They are called microdeletion syndromes because the deletions or duplications that lead to these syndromes are less than 5 MB and not amenable to be picked up by a routine Karo typing. So there are some targeted tests that were actually used to pick up, but then you have to have a hypothesis. You have to think that this is the Williams syndrome or this is the Dijot syndrome, and then you can use these kind of methods like FISH or fluorescent in situ hybridization to confirm whether your diagnosis is correct or not. Then we got a very useful test to use, and this actually came as research testing that soon moved to the clinic, which is the chromosomal microarray. So earlier, what we used to do was known as array CGH, but now we have a SNP-based chromosomal microarray. So I would not be going into too many technicalities here, but just simply to explain how a chromosomal microarray works, we take the patient DNA and we amplify. Like for every genetic test, we have to amplify whatever DNA, patient DNA we have. And after amplifying, we shear it or we break it down. And then there's a chip. On that chip, there will be several probes that are there, and they are from the reference genome or a supposedly normal genome. And then this patient DNA is actually, it will go and hybridize itself to this chip. And after it hybridizes to this chip, we can actually find out what are the losses or what are the gains, or where in the genome are there deletions or duplication as compared to a normal genome. So this is to find out in a simple way where are the deletions or where are the duplications as against a reference normal human genome. So this is what in an unbiased way a chromosomal microarray is able to provide us. So there are several applications. Postnatal, there are 3 applications now. So it has replaced most of the indications for Karo typing. So Karo type usually we would do when we have in mind that there is a balanced translocation in the parent, or if we can see there is a Down syndrome in the baby, we really do not have to go for sophisticated testing. For chromosomal disorders, for sex chromosomal disorders like Turner syndrome, for looking at balanced translocation, we still use Karo type, but for most of the other things, it has been replaced by a chromosomal microarray. So postnatal applications includes any child with intellectual disability or mental retardation, autism spectrum disorder, and any child with any kind of congenital anomalies with or without intellectual disability. So we come to today's discussion about the prenatal recommendation. So according to the international societies, reputed societies, all women who are of any age who are undergoing prenatal diagnostic testing for any reason can be offered chromosomal microarray. However, there are very ifs and buts when it comes to our scenario. Then fetus with one or more major structural abnormalities definitely calls for a CMA. Structurally normal fetus, again, undergoing prenatal diagnosis. Here, they say that even Karo typing can be done if there are no structural abnormalities. However, CMA can also be done. Then fetal tissue, whether it is after fetal death or stillbirth, can be subjected to CMA. And however, we should remember that all these tests need extensive pre-test and post-test counseling that we will talk about in a while. So even from the Canadian Society, all the indications remain almost same. So we should understand that more the anomaly or the more severe the anomaly, more are the chances that you will get a more clear-cut result in a microarray, as you would see in a Karo type as well. However, if there are subtle abnormalities, the chances that you get a positive result might be quite less. So to understand what do we get when we do microarray, I will just introduce a term which is called a copy number variant. So copy number is quite simple to understand. Variant is a difference. So here, earlier we used to have the size cutoff of 1 kb. So any segment of DNA which was 1 kb or 1000 base pairs or more. Now this has come down to 50 base pairs. So any segment which is more than 50 base pair is called a CNV, and that differs in number from the reference genome. So we know that everybody usually will have 2 copy numbers. So a copy number of 2 is considered to be a normal copy number. If there is 1, then we know that there is a loss of 1 of the copy of this genetic material. And if there is a duplication, we know that there is a gain. So by itself, CNV does not mean anything. It has to be told or interpreted in the correct terms, like it has to be told whether there is a copy number loss or a deletion, or a copy number gain or a duplication. And also it needs a classification. So any lab which just reports a CNV would not make any sense. They need to classify as per the current ACMG recommendation as either benign or a variant of uncertain significance or a pathogenic variant. So CNV interpretation, again, is quite challenging if it is something which is recurrent. So if you get a 22q11.2 deletion and you in the scan, you had a conotruncal heart defect, it will be quite easy for us to manage in the clinic because we got copy number loss or a microdeletion syndrome segment in the result, and even the phenotype is actually matching with that. So it is quite easy, but however, several times what we get is these non-recurring CNVs. That means they have not been seen in the patients before, and they may not be matching with the phenotype in the fetus. And then it becomes very challenging to interpret these CNVs. So these extremely rare CNVs often pose a significant challenge for us to dissect in the clinic. So there are several databases that are there. So there is a web source called ClinGen. So it gives dosage information, like if you do not have 1 copy of this particular gene, will it really result into a particular phenotype? It's given very well in ClinGen. OMIM has a lot of recurrent syndromes, which I was referring to. Then Gene Reviews is a very good source for reading about a lot of microdeletion syndromes. And whenever we have a CNV, we have to look at the disease database. So whether other patients have been reported with the same phenotype or not. And also we need to look at the population database. So the interpretation is quite complicated because your CNV in question, it should not be present in normal people. It should be present in databases of people who have disease, and then it should match with the phenotype. So these are the things that have to be considered. And how do we report the results? We have to consider all the recommendations by the American College of Medical Genetics that they keep updating from time to time. The CMA platforms should be as extensive as possible. They can be of same resolution like we use for postnatal CMAs, and usually reporting of 500 kb of more than 500 kb of deletion and more than 1 MB of duplication is recommended when it comes to prenatal setting. And we refrain from reporting any variants of uncertain significance, and usually like to report the pathogenic and the likely pathogenic variants. So there is role of pre-test and post-test counseling. So every CMA that is being done should be should have a formal informed consent telling about the technicalities of the test, the limitations of the test, the utility of the test, the procedure risk, everything. And also inform the patient very well about the limitation, the possible outcomes, especially if there is some uncertainty that arises in the test result. Often for non-recurring CNV, that means which are seen only in this patient and have not been seen recurrent in the literature, might pose a challenge for interpretation, and sometimes you need to check the parents. If it is coming from the parents, it is a good evidence that it might not be disease causing, or it may not actually be resulting to the phenotype that you are seeing in your patient. Then a lot of educational material is just good to have in the clinic if you're doing a complicated test. And ideally, this should all be done under the care of a expert who will be able to handle all these complexities in the clinic. So what are the advantages of CMA? Whatever are the disadvantages of Karo Type are the advantages of CMA. So it can analyze any, we can analyze or we can test DNA, which can be taken from any tissue. So we do not need live cells as opposed to a Karo Type, in which we need live cells to begin with. We have to culture them and then we have to arrest them in the metaphase and do a Karo Type. So you can just extract DNA from any fetal tissue and then subject it to microarray. And then there are several kinds of platforms that are available for CMA. So whatever specifically you want to look into, you can have that kind of customization. Then this is definitely a high resolution test. So whatever you thought you're going to miss in Karo Type, all that you would be able to pick up when you're doing a chromosomal microarray. That sometimes becomes a problem as well, because you're going to pick up smaller deletion and duplication, and their interpretation can sometimes be challenging. And then you have an objective interface of data, as opposed to a lot of subjectivity that is there when it comes to Karo Type. So Karo Type is very much dependent on who is looking at it and how they are interpreting the result, and that would make a lot of difference in what is being reported back in the Karo Type. Then there are other things that can come out, like a region of heterozygosity, which can be important for diagnosing things like uniparental disomy. And definitely, as I said, it's a ready interface of data, so it is very easy to analyze for a lot of people. So these are the limitations. So some genetic variants that it cannot detect, as I said, is balanced chromosomal rearrangement. So if you have a family where there are a lot of pregnancies with multiple malformations or several losses are there, and then you are thinking that the parents have a balanced rearrangement, then that is where you cannot use microarray. You have to use a Karo Type. Low level mosaicism, then sometimes tetraploidies can be missed, and definitely the regions that are not covered in that particular platform which you are using, they would not be picked up. And also very, very small deletion duplication for which your platform doesn't have a resolution may not be picked up. And then what we are actually picking up is only copy number variants. That is what we should remember. We are not able to pick up the other genetic defects, that is either single gene mutations or expression or methylation abnormalities, etc. So in the interest of time, I think I would just discuss one or two cases. I had some 3 or 4 cases, but I think I have already crossed my time. So this family had come to us with 3 pregnancies. One was an early loss, and the second, there was an ultrasound report of a Danby-Walker malformation, and again, that was terminated. In the third pregnancy, there were renal abnormalities, cleft palate, and tetralogy of palate that was reported. So in view of really guarded prognosis, the family decided to terminate the pregnancy, and they got the fetus to us for autopsy. So we can see that there is a lot of facial dysmorphism. There was cystic hygroma. There were contractures as well, and there was TEV. Internal examination, we could validate there was a cleft palate, there was a VSD, there was a large dilated aorta, and then there were renal anomalies. One of the kidneys was very small, and the other was cystic and it was dilated. So we were looking at multiple congenital anomalies, and then we decided to do a CMA from the fetal tissue here, and this is what we got. There was a big duplication at chromosome 3 long arm, and there was a deletion, again a very huge one at the short arm of chromosome number 5. So this is what we refer to as a double segment imbalance. That means there is a duplication in one of the chromosome and there's a deletion in one of the chromosome. And this double segment imbalance usually happens when one of the parent is a balanced translocation carrier. So we are still yet to see this family back, but we have asked for a parental karyotype, and we know that one of them definitely is going to have a balanced chromosomal translocation. This was another family here. And the first pregnancy was again lost quite early. The second pregnancy also lost early. And then in the meantime, when 2 pregnancy losses were there, they had actually already got a karyotype done when they came to us. So this is the husband's karyotype. Wife's karyotype was normal, but if we look at the husband's karyotype, we can see that this chromosome number 16 in the karyotype, the P arm is missing. So that is what was reported, that there is a deletion in P arm. But practically, if we see, this is almost impossible because he was healthy and he was absolutely fine. And if somebody is missing so much of a chromosome segment, we don't expect them to be alive and healthy and do not have any physical and mental handicap at all. So they when they came, they already had unfortunately pregnancy, so we had to decide what to do in the pregnancy as well. So we decided to go ahead with amniocentesis and do a karyotype as well as CMA, because we do not have a in-house CMA. We thought we will do karyotype as well, which we had in-house, and simultaneously do a CMA as well, because this was quite unusual. So when we did the karyotype, we could see that there was same abnormality that was there. So if this kind of karyotype is given to for interpretation to me, I would say that there is a chromosomal abnormality, there is loss of half of the chromosome 16, and this definitely is going to lead to a lot of problems for the baby later, whether physical or mental or both. However, this is what the final result that I wanted to show. So the lady's karyotype was normal. Karyotype of husband carried this mutation or carried this deletion in chromosome 16. Then karyotype of fetus, we saw that it carried the same deletion that was there in father. However, the CMA was normal. So it means that this abnormality, I can just go back here, it has not been reported correctly. This part of the chromosome, which we were seeing missing here, actually has gone and joined elsewhere in one of these chromosomes. But when the resolution of the karyotype is less, we may not be able to pick it up, and that might lead to Adonis reporting. So the father was normal and had a balanced karyotype and balanced genome, as well as the fetus had balanced genome. But if we did not do a CMA, we could never be confident whether the fetus had a balanced genome or not, and there was no imbalances at all. So in the interest of time, I think I would just skip this, and then I would be happy to answer any questions if they are there. Thank you so much.
Thank you, Dr. Shukla. Very interesting. And really, I'm so glad that you started absolutely from the basics and then built up the momentum towards more complicated and complex matters. Thank you very much for your talk. There's a question for you. I can't see who has asked this, but the question says when to use whole exome and Sanger sequencing.
Yeah, so thank you for asking that question. As much as possible in prenatal setting, we like to keep the testing targeted. So anytime, because there are a lot of OBGYN specialists here, I would like to give this message that please send appropriate referrals or timely referrals. If a family comes to you in the preconceptional period and they already have an affected child, we should not be waiting for them to get pregnant and then start evaluating the child. And this is the message that we give to all our pediatric friends as well. because the evaluation of a genetic disorder is not easy. It might need many tests before we arrive at a diagnosis. So luckily, we have very sophisticated tests available at most of the centers who are doing genetics in India. And most of the children do receive a diagnosis. But unless and until any child receives a diagnosis, it is not possible for us to tell them what is the risk of recurrence for that particular disorder in the family. So that is the ideal time. And then once we know what is the disorder in the family, then we usually like to do a targeted testing in the pregnancy. And for that, usually we do the gold standard method, that is the Sanger sequencing. So we, as per the international recommendation also, an unbiased test like exome sequencing, which is difficult to and very challenging, even in the postnatal scenarios, should not be used at this moment for doing any kind of prenatal testing as much as possible, unless and until by using that test, again, you are looking for a specific mutation. So it is always necessary that you already know what you are looking for in the prenatal setting.
Got it. So I think
so
it's
not like this. Sorry, Parikshit. It's not like this that if you can't find anything, just order a whole genome sequencing and exome. It's not like this. This message has to go very clearly that an exome sequencing and whole genome sequencing does not mean it tells you everything about every disease you have.
Definitely.
So that we need to be very clear.
Yeah, so that is why even if we look at the microarray results, we like to report back the pathogenic and likely pathogenic, and we get if we take the cutoff of 500 kb of deletion and 1 MB duplication, we really are going to get 1 or 2 or 3 variants maximum. But when you look at exome, because we do this in-house at our place, it is like we are going to get thousands of variants, and it's almost impossible to dissect them out in a prenatal setting where you do not even know the complete phenotype of the fetus. So we should stay away from those kind of tests as of now.
Great presentation. Thank you.
Thank you very much.
Thank you, Dr. Anju Shukla, for such a wonderful and informative presentation. Thank you, Dr. Parikshit sir, for joining us despite your busy schedule.
My pleasure. Thank you.
Can we go ahead with the rest of the sessions, please? May I now have the opportunity to invite Dr. Rishma Pai, ma'am, who will be conducting the third session with us. Welcome, ma'am. She is a person who needs no introduction, our past president of FOGSI. Ma'am is an honorary consultant at Leelavati, Jaslok and Hinduja Hospital and has various accolades to her name. And she is a renowned faculty for infertility. And we always look upon ma'am for her opinion about ART and infertility related issues. She's been a past president to multiple organizations of national and international repute, including FOGSI, ISAR, IHE, and has been awarded with multiple rewards. So ma'am, please could you take over the session and introduce our debate panelists?
Thank you. Thank you so much, Aarti and the entire young team of Sheetal and Sheila and Rohan. And of course, now the senior Niharika, the chairperson, is doing such unusual and different activities. I saw the program and I was like, oh my God, now youngsters are discussing all these not so often discussed yet complex and very important issues. So congratulations for taking up these rare topics for discussion. And of course, Dr. Narendra Malhotra, the man and the mind behind a lot of these new things which happen. So huge congratulations. And thank you for being there, Narendra. You're so enthusiastic. It's fantastic. So I look forward to this debate because to me, it's really interesting that nowadays almost everyone is doing single embryo transfer. And obviously that embryo or blastocyst has to be selected to make sure it's good because only one single selected blast is being transferred back. And of course, these two main systems of analysis, whether it's the non-invasive method, which is very attractive if it works, and of course, the pre-implantation genetic testing, which has been there for a while and is now the gold standard. So we look forward to hearing our two young speakers, Dr. Rohan Palshetkar, of course, who is the head of unit at the Bloom IVF at DY Patil, Mumbai, is the second Joint Secretary of AMOGS, Joint Treasurer of the Maharashtra IIG chapter, managing committee in MOGS and MSR. And I'm wondering how he's getting time to prepare all these new talks, looking after all these things. He's won so many awards, so really distinguished career in the short time that he's been in the gynec community. So really look forward, Rohan, to hearing from you and really wanting to know who will win this debate. I think it's important for all of us to know that. So whoever wins, all of us will follow that person and start doing that procedure only from now on. So Rohan, looking forward, and then we'll have a little discussion later on. Of course, Keshav, you want me to introduce both of them? Lovely. All my favorite people are on this debate. So I don't know which side to be biased. I want to be biased both sides. So Keshav Malhotra is, of course, certified clinical embryologist, one of our very young, dynamic, upcoming, good-looking embryologists, extremely rare to find. He's a master of clinical embryology from Monash, from Australia, and a Bachelor of Medicine and Surgery way back in 28 to 13. So really bright, as you can see, with all the multiple distinctions and gold medalists that he's got. Again, look forward, Keshav, to hear from you and the work you do at Rainbow Clinics in Agra. So let's start the debate.
Yes, ma'am. I hope you're able to see my slides.
Yeah.
Yes.
So the outset, thank you, Rishma ma'am, for such a kind introduction. And Niharika, I would like to thank you for giving me an opportunity to be a part of this webinar. And I would like to thank our president, Foxy, Dr. Shanta Kumari ma'am, Dr. Madhuri Patel, our general secretary, and the vice president in charge, Dr. Basab Mukherjee. So today we're going to be talking about NICS versus PGTA, or non-invasive PGTA, as I would say. So I'm going to be talking on the side of non-invasive. Keshav, my very dear friend, is on the opposite side, and usually we actually get along really well. But today I'm going to have to try and disprove him in a field of his expertise. So Keshav, I do understand that PGTA is the gold standard, and because aneuploidy is now very common in embryos with a 20 to 80% incidence, especially depending on the female age. So aneuploidy can result in recurrent implantation failures as well as spontaneous abortions. Now, usually whenever we're doing a transfer, we do a morphological analysis according to the Gardner and Schoolcraft grading, but this can't really tell us whether the embryo is euploid or aneuploid. So we require more measures, and as we know that PGTA is one of the additional methods. The most common PGTA method is the trophectoderm biopsy at the blastocyst stage. And as we know that this is the thing that's been carrying on. But PGTA, why am I talking about it? My talk's on NICS. Because PGTA is not foolproof. It has its pitfalls. One, it requires its embryo manipulation. It requires...
Sorry, do you have slides? Because we can't see them.
The slides are not moving?
Slides are not moving, Rohan.
Okay, sorry. I'm just going to stop share and go back to it. Can you see the disadvantages of PGTA?
Yes.
So yeah, Keshav, I get a chance to disprove PGTA once again. So as I said, that it requires your embryo manipulation in the terms that you require trophectoderm biopsy. You need to perforate the zona. There's a high degree of skill required. Keshav, everyone is not as skilled as you. We need experts more like you in the field, but the training is going to take a lot longer. In addition, we need a lot more equipment, and the cost of the equipment is high, as well as the operator training. A trophectoderm biopsy, we are all moving to single embryo transfers because we want to try and reduce the risk of twin gestation, the complications that are associated with it. And as it is, we know that there's PIH. So trophectoderm biopsies have been linked with even with a high incidence of PGTA. So we want to make the obstetric journey of the patient also more comfortable. So as I said, the embryo trophectoderm biopsy, the outcomes are more operator dependent. The biopsy is a highly technical procedure. Not everyone is trained to do the procedure. And even though trained, there need to be enough procedures to maintain that skill. It's not that every lab has that facility, or rather that trained operator to conduct this process. So why does this trophectoderm biopsy, which we've considered the gold standard, sometimes it cannot work? Because
Slides are not moving, so sorry.
Okay, can you see my slides now?
Yes, now we can see.
I think I'm just going to maybe not put it in slideshow mode. We can just
do like that. Yeah, this is okay.
So when we're talking about a trophectoderm biopsy, I just want to show this one photo and then go on. Yeah. So even under the assumptions of even distribution of the aneuploidy in the trophectoderms, it's not reflecting the entire embryo. So it would require at least 27 trophectoderm cells to be diagnostic for the trophectoderm alone. This is what Gleischer said in 2017. So when we're looking at the biopsy, even if we take one part which is euploid, but the inner cell mass is aneuploid, we can get false negative results. So that's what I talk about, the inner cell mass. And abnormal embryos at the blastocyst stage can even self-correct in humans. So are we able to give a complete picture to the patient when we're doing this? So let's get this light bulb, which has now been knocked off in our heads recently. We need a non-invasive approach with the same benefits of PGTA. Because what does PGTA do? It's improving the live birth rates, it's reducing the time to pregnancy, and it's reducing the miscarriage rates. But it has come with its own problems. So that's where NICS or non-invasive PGTA comes into play. Over here, what do? We create the embryo, we grow it up to the blastocyst. Now, the culture in which the blastocyst is growing, we collect that spent culture media. We do a sample preparation by either whole genome amplification or by the Malbac technique. Then we expose it to the NGS sequencing, and we're able to get a report of what the embryo actually looks like. So, sorry, I think my slide repeated, sorry. So what are the advantages of NICS? One, that it's non-invasive. That means we don't have to take a biopsy at all. It's just from the culture media. So the embryo has no damage. It's a lot easier. We don't require that much technical expertise to pick up the culture media and send it for testing. As I said, no sample loss because there's no, it's non-invasive. High sensitivity in the sense that it still has a very good chance of detecting the chromosomal abnormalities. It's flexible. That means it's compatible with the various platforms, especially the NGS platform, which is being more commonly used, and it's compatible with AI. With the new ERICA platform, we can actually combine our NICS with the morphological analysis and get a better result as well. Now, as I said, we want to represent the whole embryo. It's not just the trophectoderm. So Rubio et al. In 2020, where he studied over 1,300 embryos which were undergoing PGTA, he took the spent culture media of all the embryos and analyzed the cell-free DNA. This is basically the NIPT where we check the cell-free fetal DNA. Here we're just taking the embryo cell-free DNA. So what he did was even the ICM and trophectoderm biopsies were performed on the embryos that were donated for research. And what he saw was that the concordance of the cell-free DNA from the spent culture media mass and ICM was similar to that between the trophectoderm and ICM. So what does this actually mean? It suggests that the cell-free fetal DNA in the spent culture media is coming from both the trophectoderm and the ICM. Therefore, when we're considering doing the non-invasive PGTA, we're getting a representation of the whole gene, of the whole embryo. Another advantage is that it doesn't require any extra equipment or requirement. You just have to take the culture media and send it to the lab for the testing. And your results are going to be consistent irrespective of whether you're culturing in all the various incubators available. In addition, you're also, whether you do IVF or ICSI, you get the same results. Now, I'm sure Keshav's going to bring this up that, Rohan, no, your concordance rates are not going to be the same as your PGTA, because PGTA has been proven to have good results, and it may not be the same as NICS or non-invasive PGTA. But just look at the studies. You have these studies, look at the 2018, then going to 2019, going to 2020 and 2021. You can see the results improving year by year. And you can see the concordance results are there. And the studies are small, no doubt. NICS is still in its infancy and it's growing really well. So what I'm trying to say is the results have improved time to time because one, the contamination level which is there is reducing, because we're learning how to standardize the process. We're learning how to improve it to a point where we'll have equally good rates. Remember, when even NIPT came in, there were a lot of debate on this, whether NIPT is going to be as good as dual marker and your NT scan. And today, NIPT can give you almost 99.5% accuracy when diagnosing Down syndrome. So what I'm saying is NICS is reaching that point where we are going to get really good results and be able to get the reports as much as we want through PGTA itself. So what I'm saying, okay, I think I just ended up deleting, sorry. So
I might want to interrupt you here. You just have last 1 minute to go.
Yeah, I'm done. Don't worry, look at my slide. The end is near. I'm at the end of my presentation, Aarti. Don't worry. So what I want to conclude by saying is that the trophectoderm biopsy, yes, it's the gold standard for PGTA currently. But remember, it's technically difficult. It's a lot more costly. It requires a lot of infrastructure. Non-invasive techniques are showing promising results. And in combination with the morphological assessments, NICS is going to be the future for PGT, and it's going to be the way forward, and it's going to overtake everything else. So thank you so much for a patient hearing.
Over to you, Keshav. Dr. Reshma.
Thank you, Rohan. Yeah, thank you, Rohan. That was very nice, short and sweet, and definitely gave a very good comparison between the two techniques. So let's hear what Keshav has to say, and then we shall fight it out.
First of all, thank you to ITP committee for inviting me here. Thank you, Reshma ma'am, for that wonderful introduction. It's an honor to be debating before you. Rohan, you've made my job really easy with your slides. I've taken a screenshot and I'm going to put it in my slides right now as well, because obviously what you've spoken about is a complete hype, and that's what I'm going to basically discuss today. Now, we know that PGTA is itself not as good as what we wanted it to be. We would still call it a castle built on sand. And if a wave comes, it just takes the castle away. And the main reasons why we've really not done well with PGTA is that we're still not sure what to do with mosaic embryos. We're still not sure whether the trophectoderm is a true reflection of the blastocyst itself. And we're still not sure whether there is some self-correction happening, whether these embryos will implant or not. We're still not sure about all of these issues. Now, based on all of this, what we're trying to do is, instead of improve upon a current technology, we're trying to deviate towards removing a certain aspect which people feel would be a limiting factor, which is the skill of the embryologist. Now, I'll debate upon this as well, because it feels like non-invasive PGTA is very easy. Everyone can do it, but honestly, it's not. And that's one of the reasons why the concordance rates are actually pretty variable as far as all of the clinics are concerned. Now, what non-invasive PGTA means is basically you take cell-free DNA, put it in a tube, do Malbac and do the whole genome amplification, and then basically do the analysis. And it gives a report similar to pre-implantation genetic testing. What it's being used as right now is an embryo ranking tool. It's not being used as an embryo screening tool. So this is also something that we have to understand. And any of these embryo ranking methodologies which are available, be it morphogenetics, be it artificial intelligence, be it non-invasive chromosomal screening, they are all add-ons in our field. And we have to understand that we have to responsibly use our add-ons, because the kind of population that we deal with, most of the patients don't really understand the kind of implications a test or even a simple diagnostic test would bring with it. They would think that you're doing a genetic test for them, but you're not actually doing a genetic test. You're just ranking the embryos and you're trying to predict which one has the best possibility of being euploid, which one has the worst possibility of being aneuploid, something like that. Now, how reliable is cell-free DNA? Now, we have looked at Rohan's presentation. We have looked at the slides. And again, this is the same data that I'm producing. Concordance rate with trophectoderm biopsies is 89%. Concordance rate with ICM biopsies is 84.5%. Now, we have to understand that for a test to be reliable, it has to reach a concordance rate of over 98%. Unless and until we reach that concordance rate, this test is actually useless at the moment. Now, we also have to understand that we don't really know where this DNA is originating from. So what has been hypothesized is that you have blastomeres which are growing inside an embryo. Some of them undergo apoptosis. And during this process of apoptosis, there is some release of DNA which happens, which comes out into the spent media. And this basically is what you're going to assess. Now, is this DNA, which is coming out from a dying cell, which is coming out from an apoptotic cell, actually going to reflect the reproductive potential of the embryo? We are still to actually ascertain, because there are no studies at the moment which would actually compare this, and there are no meta-analysis which we can actually use to actually say that, yes, this is actually useful for us or not. Another issue that we have to deal with is that there is a certain amount of necrosis which also happens during embryonic development, which also releases DNA, which might not be great. Now, if you look at apoptosis, and this is a study which was done way back in 2001, this is basically comparing DNA originating from apoptosis to necrosis. And we can actually see that the size of the DNA is less as compared to apoptosis. And again, there are what else it's telling us is that there's so many factors, especially when you look at necrosis, where you're looking at stress. There's so many factors within the laboratory that can also affect the composition of DNA, especially in your spent culture media. So that's again something that we have to worry about. There are lots of technical questions that also need to be answered. What type of amplification to use, how much culture media to be used for the embryo to grow in, what's the best timing. There's no standardization at the moment. Some people say day 5, some people say day 6. Most people are actually saying day 6 might be better. But when we grow embryos till day 6, the day 5, the blastocysts that are there on day 5, you're actually compromising their quality by growing them by 1 more day. So that's again a problem for all of us embryologists to really look at. And this is something that we have to deal with when we talk about this technology. We know that PGTA itself suffers with this problem, which is related to mosaicism. And NIPT again has the same issues. We are still not able to actually reliably amplify such DNA. We are still not able to really predict the mosaicism percentage. And based on this, are we giving a true reflection to the embryo? Are we giving a true selection? We're not sure. Now, looking at certain concordance issues, if you look at spent blastocyst media versus ICM, you look at the false positive rates and the false negative rates. Big problem. Anything above like 3%, 4%, or maybe even 2% is a problem for all of us. And that's again something that we can't really deal with. We know that the first baby of NICS was born way back in 2016. And there itself, in that paper itself, there are issues that the author has spoken about, issues regarding false positives, issues regarding mosaicism, issues regarding contamination from maternal cumulus cells, from sperm cells, especially if you're doing IVF. There are lots of issues. Now, it's not that easy. Rohan is saying you can only do it, you can do it for IVF, you can do it for ICSI, but it's not the case. There are lots of contamination issues that we really need to deal with. And especially when we're talking about 5 days or 6 days of culture, the amount of handling that the embryologist is doing, the amount of contamination that can come from the embryologist itself is going to be a problem. This was the data that Rohan was showing from Rubio et al. Now, if you look at this data closely, now I've analyzed this paper very in much detail. The outset looks fantastic, great concordance, okay, false positive results, etc. But you look at all of the centers that are there. Now look at concordance rates between center 4 and center 7. There is a huge discrepancy there, which ultimately tells me that it's not standardized. It can't be validated for multiple centers. And that's another problem for all of us. Now, why can't it be validated for multiple centers? Because culture conditions vary. Our culture drops vary. The group, whether we are doing single culture or group culture, that varies. The kind of media that we do, look at this slide right here. The brand of the media, the concordance rate varies with the brand. The incubator model, contrary to what Rohan was saying, you can do it with every incubator. The incubator model, the concordance fluctuates with different incubators. And that's again something that we have to really, really think about, because we're thinking about a test and we're trying to give a global approach to it. But because there are so many conflicting parameters in each laboratory, the atmosphere is different, the air quality is different, the embryologists are different. When you look at it in comparison to PGTA, you're taking 5 to 7 cells and you're sending it for analysis, nothing else. That's it. But when you look at NICS, you now have to control all 6 days of culture. You have to control each and every minute detail of embryonic development. And that is what's going to actually give you concordance. And that is no easy task. I think it requires an even more skilled embryologist, whether when compared to doing just embryo biopsy. Looking at different amplification methods.
Last 1 minute to go.
Yeah, just finishing. Amplification methods again are a problem. Now, if you look at the concordance rate with the different amplification methods, really varies quite a bit. This is the new data that has come up. Again, if you look at concordance ploidy rate, 78%, 74, 88, 63, 74, and these are all 2021 good meta-analysis with good number of embryos being analyzed. What Rohan showed you was what, 4 embryos, 100% blast, 100% amplification. Now, I mean, this is a data which obviously should not be included in a debate like this. Now, what are the other risks? DNA contamination from humans, from labs, from maternal and paternal sources, different culture conditions, etc. All of these are issues. There's a huge variability. I've already told you that. And this variability does not even exist. It's not just variability in the culture conditions, it's variability between the patients as well. So not all patients require PGT, not all patients would require NICS. Cost is another issue. Now, companies that are doing NICS in our country are charging the same amount as doing PGTA or embryo biopsy. So it's the same 15,000 per embryo. Or if you go down to, if you do more than 5 embryos, it comes down to 11,000 per embryo. So big problem again, because the cost is not changing. Last thing, legal issues. So this is a major lawsuit which happened in Australia for a clinic, which actually discarded embryos which came out abnormal with non-invasive chromosomal screening. And ultimately, because the test was just a ranking test and not a diagnostic test, the clinic actually ended up in a lawsuit. So these are certain challenges that, especially in a country like ours, where our patients are not as educated and we don't take those consents, unless and until there's a proper informed consent, unless and until we are actually telling the patients what we are going to do and how we are going to interpret the results and how we are going to use the results, this test actually does not have much value at the moment. I know that there is a lot of future for this test. It's developing still, but if you look at the current data, absolutely, I would be very against using non-invasive chromosomal screening for my patients at the moment. So with this, thank you so much for your patient listening. And Rohan, if you want to rebuttal.
So Keshav, I completely agree with you on that part, that NICS is not currently, you are absolutely right that trophectoderm biopsy is the way right now, is the gold standard. But what I'm saying is it's showing a lot of promise. When you spoke about apoptosis and we're unaware about the DNA, where exactly it's coming in the spent culture media, Vera Rodriguez in 2018 also said that even though the apoptotic cells were originally considered back in 2001 only, when they said that was the reason, she showed that it may not be the actual cause of the releasing the DNA. It can be from the inner cell mass as well. Regarding now, I'm glad you brought up the part where the ethical issues of it as well, where it comes in. A lot of countries don't allow biopsies and don't allow PGTA to happen because you're not allowed to touch the embryo. In those countries, we would be actually be helpful in the terms of using NICS, and that would really help. Keshav, I don't like us arguing, honestly. In fact, this is, I think, the first time I think we end up having such a heated discussion, or rather a friendly one, I should say. In addition to that, I completely want to say that NICS is going to be changing the future. As I said, that NIPT, when it came in, it was being questioned about whether it is the right screening, what additional information, because I agree with you, what you said, that cost is a factor. It's very expensive. In fact, Archana Verma ma'am also said at the start that it is very expensive and we can't afford to give it to everyone else. See, as we go in the medical field, we end up seeing that the more and more it gets standardized. And I love the fact that you brought up my slide about 4 embryos. It's not enough. And obviously, even I was like shocked when I was reading that. I was like, okay, 4 embryos, obviously there's a high chance that we can get 100% result. But remember, at every center, there is going to be a pilot study where you see promising results. As an may I just share one slide quickly, because that's something which because we were running out of time, I was unable to show. Look at the study by Lee et al. In his first study itself, you see that it's 78.9%. And look at the second study, again, when he did it in 2021, his concordance rates are increasing to 90%. So if you see, I'm not denying the fact that there is a variability, but a way of standardizing this process, we're getting to the point where we are getting better at this. We are improving our technique. we are improving our quality. I'm sure when we started off, I did say that trophectoderm biopsies are more skilled, but I'm sure, Keshav, now as we've come to the point where we're doing it a lot more often, it's getting easier. It's like how an MBBS or MD student says that when we're doing our first cesarean and when we do our 25th cesarean, the hand gets a lot easier. The technique becomes much better. The standardization of processes also becomes easier. Look at the antagonist protocol, which is being used. Now we're shifting to the progesterone prime technique. So all these different techniques did eventually get standardized, eventually have now become a part of the future. And now they're going to be the standard going ahead. So that's where I feel that NICS is a promising futuristic procedure, which will eventually get standardized and become the gold standard over PGTA. Now, Keshav,
Okay.
don't fight with me.
I'll keep it very short. I think the biggest problem that we have right now is that we're interpreting this test to become completely something else. We're interpreting it to be a replacement to pre-implantation genetic testing, which it's not at the moment. And it's not being advertised as that as well. So it's only being advertised as a test which can rank embryos on their potential to be euploid or aneuploid. Now, if we stick to that, and if we don't confuse it with that, I'm okay with the use. And as long as our patients understand that this is what we're doing. Now, if you're telling your patients that you're doing a genetic test and you're putting in a euploid embryo or using NICS, then it's a problem because we don't have the concordance levels. So till we achieve those levels, we can use it maybe to rank. We can use it like a replacement to morphogenetics or artificial intelligence or something like that. But till it reaches concordance and till it reaches concordance of 98% in variable multicentric conditions, that's when I would actually start advocating this test.
Thank you. Thank you, both of you. It was really, I actually like a seesaw. And I mean, I think we really valid arguments, and I'm so glad both points were brought across so strongly, because it's really important for us to know in the era of single blastocyst transfer, where we now know that morphology is not reliable. We need a system, and we do know that though they say PGTA is the gold standard, it's far from perfect because of all the issues which Rohan has underlined, you know, the invasive nature, the expertise, the risk of obstetric complication. That's the biggest problem. And again, there is the whole problem of mosaic embryos, which comes up every now and then. And you did talk about, you know, the Australians issue where they discarded those embryos. But I think similar thing can happen even with mosaic embryos being discarded, which may eventually either autocorrect or turn out to be normal, give rise to a normal newborn. So there are lots of discussions and debates. I think NICS is really in its initial stages, but going forward quite okay. And you all have quoted such lovely studies, and I myself was reading the Lee Chen's 2021 study. It's 265 embryos comparing NICS with trophectoderm biopsy with whole embryo biopsy. So that's like an amazing study. And the kind of results that have come out, the negative predictive values, I think like 92 and 91 for both. So they're like exactly similar. So we are getting there slowly but surely. And for even for a patient, when we advise them that we're going to biopsy the embryo, you know, laser cut it, put inside, take a, it's a little scary, though in expert hands, it's being done worldwide and it's giving really good results, not injuring the embryos very much. But if you say, okay, I'm just going to take the water around the embryo and I'm going to analyze it and give you good results, it's very attractive for the patient. So I'm sure over a period of time, you know, it will autocorrect. What is best will emerge the winner. Each one right now has its pros and cons. Unfortunately, neither is perfect. That's what we want, perfection, and we're not going to get it in a hurry. So thank you both for presenting such a balanced viewpoint and for not physically hitting each other. I'm glad for that. And I don't know how we're going to come to this conclusion. I can't. Maybe Niharika has a system, buzzer, voting, raise your hands, something by which we can come to a conclusion. But I enjoyed this really. I've actually made notes and I liked the conversations and discussions. Very interesting. Thank you.
Thank you, ma'am.
Thank you so much, ma'am. Keshav, debate apart, I do agree a little bit with you also, but we have to portray our own points and show it as per this.
Absolutely.
So I think the message ahead is right now, the PGTA is the gold standard. NICS is a ranking system, and we need to be very sensitive while counseling our patients as well.
And we need to document our consents.
NICS is a screening system or a scoring system. And if there is the slightest doubt of an aneuploidy or multiple defects in the embryo, then definitely you go ahead and offer PGT.
Then you do a
You
BART.
don't rely completely on the NICS, but go ahead and do a PGT in cases which are worrisome.
Absolutely. Thank you so much.
Thank you, Rohan and Keshav, and thank you, Rishma ma'am, for being here. And it's such a pleasure that you never say no for any young talent promotion committee program, and we are always glad to have you. Just for
I say no to all of you all, yeah. You all are my bachas. I say no to everybody else, but to you all, I never do. So thank you. Thank you for being with me. Makes me feel young.
Thank you, ma'am. And this program actually are official partners with Thermo Fisher, and we thank them for being with us because they actually motivated me to do something different, and that's how we came up with this program. I also thank Science Integra for being with us today. We have a very interesting panel discussion now, and I request Aarti and Shaila to invite our moderator and panelists.
Thank you.
Thank you, ma'am.
Rishma ma'am, and awesome debate. As I mentioned earlier, also Dr. Rohan and Dr. Keshav, we thoroughly enjoyed it. And now it's time for panel discussion. And it's my prime privilege to introduce and invite and welcome Dr. Ratnapuri ma'am. Can we have her CV slide, please? Ma'am is Professor and Chairperson, Institute of Medical Genetics and Genomics, Sir Gangaram Hospital, New Delhi. Ma'am has been the recipient of Dr. I.C. Verma Outstanding Researcher Award in 2019, Dharamvira Award of Excellence in 2010, Young Investigators Award from Tokyo, Japan, and several memberships of reputed organizations like Undiagnosed Disease Network International of NIH, USA, and Diagnostics Scientific Committee International Rare Diseases Research Consortium. Ma'am, we welcome you. This platform is all yours now to generate some exciting, relevant take-home messages, especially for general obstetricians who are seeing such type of cases in their day-to-day life, me being one of them. So, ma'am, shall I introduce the panelist or?
Yes, please. That will be nice. Thank you so much for the kind introduction. And I'd request you to take forward the introduction of my panelists, and then I'll take the panel forward.
That for you because you're also one of them. So let me take this pleasure to invite the panelists. We have a young team from YTP committee here today. So we start with the youngest, Dr. Aarti, senior resident at AIIMS, New Delhi. She has won a lot of gold medal and a silver medal at MG PGI Chandigarh. She's done her ICOG fellowship in endoscopy, also visiting Sri Sri University at Calicut, and also been awarded as the Young Scholar Award. Our next panelist for today is Dr. Shaila Jamal, who is the North Zone in charge of the YTP committee. She also runs her own Society of Menstrual Disorders and Hygiene. She is the chief editor of Journal of Reproductive and Menstrual Sciences, associate professor from Bareilly. So welcome here, Shaila. We have with us Dr. Amida. Dr. Selva Priya could not join us. So Dr. Amida is MS OBGYN. She is doing her fellowship in fetal medicine under Dr. Selva Priya. Welcome, Amida. We have Shrutika with us. Shrutika is done her fellowship in reproductive medicine and endoscopy and a medical director of Bed Ansh IVF Mumbai, consultant at Fortis Jupiter and Hira Mongi Hospital. She's also the youth council member of MOGS and managing council member of Maharashtra chapter of ISAR. Welcome here, Shrutika. We have next with us Sheetal, and hi Sheetal. Sheetal is a diploma in reproductive medicine from Germany. She's done her master's in reproductive medicine in UK. She's the director of Surya Fertility Clinic and a youth council member for MOGS and a very active member of the YTP committee. She's received numerous awards. Glad to have you here, Sheetal. We have with us Dr. Apurva Pallam Reddy, consultant reproductive medicine and cosmetic gynecology from Phoenix Clinic, Bangalore, who's done a reproductive medicine fellowship in fertility training from Brussels, diploma in gynec endoscopy from Germany, and diploma in ultrasound from Chennai. Welcome here, Apurva. We have with us Dr. Veronica, Associate Consultant and Assistant Professor in Institute of Medical Genetics and Genomics from Gangaram Hospital. Veronica also is a visiting consultant at Rainbow Hospital, Agra, and runs a genetic clinic with us. She's an executive member of Society of Fetal Medicine, and her area of interest are fetal malformations and skeletal dysplasia. Welcome, Veronica. Last but not the least, Dr. Mohit Sarogi. We all have heard him, and we keep getting messages from Dr.
workshop.
The Sarovi Hospital and a consultant IVF specialist from Genesis.
Youngsters.
Also has a
Everyone has worked abroad.
Welcome, Mohit, and over to you, Ratna ma'am.
Okay, thank you so much, Niharika. And I am going to share my screen. Can you see the?
Yes, ma'am.
Yeah. So this panel is about 55 minutes, and it talks about what, when, why, which genetic tests, in what situations do we do them. That's really a very, very tall order. But I've tried to, through various cases that we see in the hospital here at Gangaram, take you through some of the common scenarios and how to take it forward. And you've been introduced to my very, very illustrious panelists. And I would like to start the first scenario, where there is this lady who's a second gravida, and the first pregnancy was discontinued because of multiple malformations.
I'm sorry to interrupt, but your
slides
slide is not visible.
Slides are
Slide
not
is
visible.
not visible?
Yes,
Yes, ma'am.
Okay. Now, is it moving? No.
No, ma'am.
Please allow share screen to ma'am.
Yeah. No, I did share. Now is it going?
Yes.
Yes, ma'am.
Moving?
Yes, yes, ma'am.
Okay. So this is the first case where she's a second gravida, and the first pregnancy was discontinued because of multiple malformations that were identified in the level 2 scan. And a FISH analysis was done because they must have suspected trisomy 18. So the FISH sees 5 chromosomes, 13, 18, 21, and the 2 sex chromosomes. And that was consistent with trisomy 18. So like we counsel, the lady was counseled that there's a 1% risk of recurrence for trisomy 18. So in the next pregnancy, she did not want an invasive testing. She was offered cell-free fetal DNA. And so this was all the obstetric management. She had not come to a genetic unit as yet. And that was normal. So the test was done at 12 weeks because the NT-NB scan was fine and it was low risk. So everything was fine. It went on like a low risk situation until at 28 weeks, there was onset of intrauterine growth restriction. And that's when the alarm bells started ringing. So what happens here? Dr. Aarti, I would like to ask you, how would you proceed in such a case? I've put the little summary of the case here. And if you were the obstetrician, would you have ordered the NIPT for her?
So first of all, thank you, ma'am, for putting up this question to me. I would like to rule out the causes of FGR, which are possible, like the obstetric causes, starting from the history examination and identifying the causes of that possibly would have led to FGR in this fetus. And then following which, I would like to perform a Doppler studies at this point to rule out AEDF or REDF or any compelling indication for termination. And then I would like to offer NIPT. I would have offered to this patient, which came out to be normal. Also, I would want to know what was the fetal fraction at this point of time when the NIPT came out to be normal for this patient. So the next thing that we can offer to this patient is a detailed anomaly scan at this point. At 28 weeks, I would ask her to undergo a detailed anomaly scan again to look out for any anomalies.
Yeah. So now, actually what is also very important from a genetic point of view, because the first pregnancy was terminated for trisomy 18, is a family history. And when we go into the details of the family history, she had a sister who had a child with intellectual disability and dysmorphism. So because of a positive family history and the fact that this lady herself had a fetus that was abnormal and it was discontinued, the fetus had multiple malformations. So therefore, it was significant that we could be dealing with something that had a common basis. Yes, of course, you have excluded all those cases. The fetal fraction was fine. There was no other cause of intrauterine growth restriction. The Dopplers were fine. So we just felt that it had some sort of a link to the first case. I'm sorry, I have not changed the name here. Is Dr. Amidha there? Yes. Dr. Amidha? Yes. Okay. So it's like, what would strike you in this case that we've already discussed? And is there some other sort of test that you would want to consider here as a fetal medicine specialist?
Ma'am, since amniocentesis can be done from 16 weeks onwards anytime, we could, if we are not sure if this is related to trisomy 18, we could offer it now as well. But if they're not willing for invasive, like you said earlier, they're not willing for invasive, that's why they went for NIPT. So we could just focus on what we can cure. Maybe if this IUGR is not related to the trisomy 18, we could do fetal sonographies for her and check how the IUGRs are coming forward, how's the baby growing, and we can just monitor that. That's all that's there in our hands, because we need to look at what is correctable or reversible or irreversible. We have to focus on what's there in our hands now.
Yeah. So what I'd really like to bring to the attention of everybody, we've had 2 pregnancies. The first one, which had malformations, which had trisomy 18, only tested by a FISH test. The second pregnancy has onset of growth restriction, but you've ruled out obstetric causes. The Dopplers are normal. And there is a positive family history of a sister who has a child with an abnormality. Yeah. So keeping all that in mind, we try to find a common link. We already have a little clue that there is some sort of a chromosomal disorder. Yeah. And when there are 2 affected individuals, we would want to think that are the sisters carriers of a balanced translocation. Shrutika, you have your hand up. Would you like to ask something?
So actually, I wanted to just wonder if this could be a pseudo trisomy 18, because there are a lot of syndromes, not necessarily trisomy 18, which could have been mistaken as trisomy 18, like the PS syndrome or the SLO syndrome, which are non-aneuploidic.
No. Your FISH has shown. See, yeah. Your FISH. So SLO, which is Smith-Lemli-Opitz syndrome for everybody, is a single gene disorder. Okay? So if we look at the genome, inside the nucleus, we have 23 pairs of chromosomes. And within the 23 pairs of chromosomes, we have 20,000 genes. So trisomy 18 is an abnormality of the chromosomes. Smith-Lemli-Opitz syndrome is an abnormality of the genes, which we cannot test by FISH test. Yeah. So because we've got an abnormal FISH test, now this is what I want to show you. So remember, I said only a FISH was done. So a FISH looked at, it took a probe for chromosome 18, if you've heard Dr. Anju's talk, and it just goes and attaches to wherever it finds 18. It doesn't tell us where in the 23 pairs it is. So it attached on this, it attached on this, and it attached on this. So it looked like a trisomy 18, but it was not a free trisomy 18. The 3rd chromosome was not lying here like we normally see. It is only when it's a free trisomy 18, there is a 1% risk of recurrence. Here, it was an unbalanced translocation because the 3rd trisomy 18 was piggybacked onto this chromosome 4, which you can only check when you do the karyotype. And because there's a positive family history, you test the sisters. So we tested the mother of this 2 affected, and we found she was a balanced translocation carrier between chromosome 18 and chromosome 4. So a little bit of 4 was in 18, a large part of 18 was in 4, but the ladies are asymptomatic because they have it all. It's not in the correct position, but it's all there. But both their children had abnormalities that were related to an unbalance either of chromosome 4 or of chromosome 18. So that was, if you just take it simply like a pseudo something, it's a pseudo trisomy 18. It looked like a free trisomy 18, but actually it was a unbalanced karyotype. So this was the baby, looked like trisomy 18, but was different. So the key messages from this case is that a family history is absolutely essential. For some reason, the pictures haven't come up, but a family history, it's so simple. It is just about sitting and asking and talking to your patient. Whenever you do an invasive test, don't do a FISH alone. It's inappropriate. You either combine it with a karyotype, or if the patient can afford, with a microarray, because that gives us a little more information than a karyotype. And it's important to see the patient in totality. Yeah, so just don't see, okay, her first child had trisomy 18, now I can do an NIPT and take it forward, because that gives us absolutely incorrect information.
So, ma'am,
So
here
now,
we would label it as a false negative NIPT.
No, it was not a false negative. There was no trisomy 18. This second child had abnormality that was related to chromosome 4.
Okay.
So thereby, the NIPT did not pick it up. Yeah, the NIPT will usually pick up aneuploidies. It is not for structural imbalances.
Right.
Yeah, so that's the message. So NIPT we only do where we are looking for trisomy 18, trisomy 13, trisomy 21, or monosomy X or Klinefelter or whatever we want to look for in abnormalities of number. It's not a test for abnormalities of structure as per the current sensitivity of the NIPT. Yeah, I know the companies say you can check all 23 pairs of chromosomes for abnormality of structure, but the sensitivity is very low and the false positive rate is high. So thereby, as per the guidelines, we just do it for this. Okay, now we come to the second case. This is a non-consanguineous couple. She's a second gravida. The first was a spontaneous miscarriage. The husband is a known translocation carrier. So he is a balanced translocation carrier. So between chromosome 5 and chromosome 6. So a little part of 5 has gone to 6 and a little part of 6 has gone to 5. So we had counseled that there is a 75% chance that your baby would be normal. There's a 25 to 30% chance that the baby can have some imbalance, and therefore we should test in pregnancy. So an amniocentesis was performed at 16 weeks. Karyotyping was done by a culture to rule out any abnormalities. So in this case, the amniotic fluid showed this result, which is also balanced. So you can see it is just like that of the father. So this is balanced, and it shows something which is called 21 PS plus. So we know that 21 PS plus is just a normal variation. It will not cause any abnormality. So the pregnancy was continued. That all is well. Now at 19 weeks, the baby started having problems. There was growth restriction. There was oligohydramnios. There was possibility of a posterior fossa abnormality. So we have a question for Dr. Sheila, that how would you guide this lady? She comes to you, you are her obstetrician. So how would you guide this lady now?
Thank you so much for putting up this question to me, ma'am. Again, going by the dictum which we always follow, take a detailed family history to rule out a genetic pattern for the disease. Since this case is already like known case of balanced translocation, who themselves are phenotypically very normal, but during meiosis, they can have embryonic like a transfer of abnormal genetic material, which can result in abnormal fertility results like recurrent pregnancy losses, miscarriages, structural abnormalities, and this is evident in this particular case. So for me, I would like to refer her to a genetic clinic, refer the couple for genetic counseling for specialized further test, and in future pregnancies, give her more personalized screening and testing and treatment has to be offered.
Yeah, thank you so much for that wonderful reply. And Sheila, one more thing that I'd like to share. Now we've got a posterior fossa abnormality, And of course, now we've got till 24 weeks where I would want to do another scan at 22 or 23 weeks just to confirm the abnormality, because I always feel discontinuing a pregnancy is such a final thing, we can't go back from it. So we must be sure that there is a major malformation. But in any case, she already had severe oligohydramnios. So I don't think that the visibility would have been very good. So in this case, if as an obstetrician, you opt and you counsel the lady or even send her to a geneticist, it would be nice if at that time, in the event of discontinuing a pregnancy, you talk to them about the importance of a fetal autopsy. And the reason I say that is they have a lot of faith in the obstetrician because you've been following them up from the beginning and you are the primary doctor. They don't listen to what we say because they've just come to us once. So if we are able to talk to them together and in the same language of the importance of a fetal autopsy for phenotyping, and I think that should be a rule for all pregnancies that are discontinued for malformations or intrauterine deaths, because we get a wealth of information from there to counsel these families for future reproductive options. Next question is for Veronica. So Veronica is in this situation where the fetus has abnormalities, but we felt that, well, it was a balanced translocation. So there should not be abnormalities because the chromosomes of the fetus were like that of the father. So would you offer any test in this clinical scenario? And could you tell us a few details about the test and what are the indications of this test in fetal life?
Thank you, ma'am. Thank you for the question. I hope I'm audible.
Yeah.
So in this scenario, the karyotype of the fetus was apparently balanced. When we use the term apparently balanced, we mean that the magnitude up to which a karyotype is able to pick up a copy number variation, that is the increase, that is the deletion or duplication, is limited. A karyotype will only pick up gains or losses that are more than 5.5 MB in size. For smaller deletions or duplications, we need to do a test called chromosomal microarray, and that is actually a brilliant test and has a lot of fetal indications at present. So we will do a chromosomal microarray for this fetus, and the chromosomal microarray is likely to be abnormal for this fetus because there are other malformations that we can see. In an apparent, a fetus which is actually balanced is not likely to have all these malformations. So as we can see in the two diagrams here, there are balanced translocation, the parents are balanced translocation carriers, and the fetus is actually showing an imbalance of the chromosomes. So an imbalance can lead to, as was discussed by Dr. Shelja, it can lead to recurrent pregnancy losses, malformations, and also intellectual disability and developmental delay in the children. So the chromosomal microarray is now the test of choice in any fetal malformation which is not otherwise caused due to a monogenic disorder, in fetuses with fetal growth restriction, and also we can now offer chromosomal microarray when our test screen is positive, as it gives us a yield of 2 to 3% higher than an isolated karyotype. The sensitivity of chromosomal microarray is much higher than that of a karyotype, as we can see a 0.6 to a 0.9% difference. So also the
three indications.
Yes, the three indications are the fetus with malformation and structurally normal fetuses who are undergoing invasive testing. All of them can be offered karyotype and can be told about the increased yield of chromosomal microarray over the conventional culture testing. And also in IUDs and stillbirth, we can offer a chromosomal microarray. It is to be remembered that this test is not very easy to interpret, so it has to be ordered and interpreted with caution. Everything that comes on a microarray cannot be taken on its face value. I am sure ma'am would agree with that.
Yeah, that's true. So I think I'm not going to repeat that because Veronica has brought it forward very well. And also Dr. Anju had talked about the importance of appropriate interpretation of the microarray. what is pathogenic and what is a variant of unknown significance. So thank you so much.
Sorry, Ratna, just
Yeah.
will a minute here. I think our president, Shanta Madam, has joined, and I would like to have her blessings here. Welcome, Shanta, to our very small, interesting discussion today on genetics and rare diseases.
Thank you, Niharika. I was listening. In fact, it was a very good discussion, but what to do? My brain is very dull in understanding genetics right from my childhood. So I was trying to actually
Good
take
evening,
in.
madam.
And what I found was the moderator
We
was
can
so
do a whole genome sequencing. We can do Madam's whole genome sequencing.
It'll be brilliant. We'll have all the excellent genes there.
We'll know the real brain. We'll know the real brain. The Iron Lady brain.
That's true. That's what I was saying. We really get the good genes from there.
Thank you. It was really interesting, but honestly, I really find all this genetics and all very, very difficult to comprehend. So I know you're doing a good job. And anyway, see, everyone need not do everything. So you all are there. So we have any problems, doubts, we can always send our patients to you all. I think that is the most important message I'll give to my Foxy members. Everyone don't try to do everything. Because these are some specialized areas. Always you can take the help of your colleagues who are good in that. So I think that is very important, because basically what we need is, we need obstetricians in the country. I want my generation next to be good obstetricians to deliver our patients vaginally, and that you have to look at people like Narendra Malhotra sir, who to date also is one of the best simple obstetricians along with all the other tags. So I think everyone should learn from that, and then you all are there so that we can take your help in all this amniocentesis, genetic testing and all. All the best, and thank you, Niharika. And I would like to apologize for being late for this program.
Thank you so much, ma'am. I'm so glad you could make it. Thank you, ma'am.
Thank you, ma'am.
Thank you so much, ma'am.
Thank you, ma'am. So we'll just carry on. So just a little message for fetuses with malformations. Take a detailed family history, because that's bedside. You will never get anything out of the investigations if you don't have a good phenotype. And if that phenotype in genetics starts from a 3-generation family history. If the couple agrees, amniocentesis, you order don't just do a fish. So either combine it with a karyotype or a microarray. And I leave the decision to wherever you are working, what is the expertise and what are the costs, because these are all expensive tests. So please don't force them onto patients. I feel we are making pregnancy very difficult situations, and we should not do that. We all were born with the same risks, and we've all done fairly okay in life, even in the era where we did not have all these tests. So let's do them where they are indicated. Postnatal evaluation of fetuses is very important. Counsel them for an autopsy and further genetic testing, and as Dr. Shanta said, in hands that are experts. So we go into the third scenario. So this is a very simple common scenario. This is an antenatal 12 weeks increased nuchal translucency. Dr. Sheetal, with this report, there are some specific points you would want to check to validate the abnormal finding that is present of 4 millimeters. And how will you guide this couple as an obstetrician?
Yeah, so to begin with, thank you very much for this question. First of all, I would like to know whether the scan was performed at what time, what was the crown rump length, because every time when we do the NT, it is very specific at what crown rump length the NT was taken. And also, whenever we do the NT measurement, we have to also see whether the dual marker was performed, whether that was normal, whether that was abnormal, because just on the basis of NT being abnormal, we cannot actually decide whether it's abnormal or not. Anything above 1.3 is basically considered abnormal at the gestational age of around 13 weeks. And also we need to understand what is the family history, whether there was a history of Down syndrome, whether the karyotype of the parents was normal or not. And based on that, also when the scan was done, whether there was an absent nasal bone, again, that kind of the sensitivity of the test increases whether there is Down syndrome in the baby or not. So that also kind of gives us an idea whether the NT scan, the NT result is significant or not.
Yeah.
And on the basis of that, you can advise the patient whether she needs an invasive testing or not.
Yeah. So, so for nuchal translucency, there are specific fetal positions that are given by the Fetal Medicine Foundation. So you like to look at the images that have been given by the radiologist, whether the fetal position is appropriate as per guidelines. And we do have NT just CRL, and NT measurements, and things above the 95th or the 99th centile are taken as significant. So they would vary over gestations, but definitely anything over 3 millimeters or 3.5 millimeters is abnormal. Yeah, so that's the important thing. So in this case, we have an increased NT at 4 millimeters. So that's relatively significant. I mean, it is significant across all gestations of the first trimester, and NT more than 3 millimeters is significantly increased. So here you would discuss with the couple that what are the causes. It could be chromosomal, like you said, Down syndrome is the commonest one, but it could be any other chromosomal abnormality. So for that, you would do a chorionic villus sampling. Yeah.
Yes.
And you would make sure that there is no maternal cell contamination in that sample. And we do a QF-PCR because that looks at the common 5 chromosomes, which are abnormal in about 15 to 30% of cases, 13, 18, 21, and 6 chromosomes. And if that is normal, then we want to look at the other chromosomes for other structural abnormalities, which you can find in about 3% of cases. Okay. And so microarray is preferred, but if they can't afford a microarray, it's all right. You would do a karyotype, but you would do one of the two. But even now the microarray is not that expensive. So this is, but we know that if all this is done and the chromosomes of the baby are normal, we need to go ahead to look at structural abnormalities, abnormalities of the heart, the fetal skeleton. That's very important. And if all this is normal, then we know that 98 to 99% that baby would be fine. So the message is that you do no termination because the NT is increased. Yes. Because we know that in a large percentage, even at 4 millimeters, 70 to 75% of the babies are normal. So we will not discontinue pregnancies of normal babies. So therefore you need proper counseling, you need appropriate testing. Do not stress the patient. And I think we have to always remember that pregnancy must be a happy experience for the couple. So I think in the correct hands, you're able to give them the correct perspective, yeah, and then take it forward. So that's really the message for this. So we would have to request Dr. Amida to come in for Dr. Selva Priya. So here we saw that the chromosomes of the baby were absolutely normal. The array was also done and that was normal. So what is the further plan for this couple? Hello?
Hello, am I audible?
Yeah, we can hear you, Amita. Yes.
Yes, ma'am. Since this increased NT is the only isolated finding, and it is known to self-correct over the time, I would just say that extensive monitoring, like a good level TFA scan as well as a good fetal echo has to be taken care of. That's it. We just need to follow up the person, the fetus, or any other things that evolve. We don't need to stress the patient, or it might just be normal, as you said. We don't need to worry about a lot of stuff. If something comes up, we'll deal with it there and then.
Amita, we find a lot of people ordering this clinical exome, and I'm sure you've come across it also in your practice for any and everything in fetal life. So would you do that? Would you do that as a fetal medicine specialist?
Ma'am, I do not think it is necessary at this point. There are, like we've heard before, if there are multiple abnormalities, we might go into it, and then also we know what to look for if it's common one. But at this point, I absolutely don't think it's necessary.
Absolutely correct. And I think that was the very important message that you have given to all our viewers, that just because a test is available, we don't do it for everyone. There are very specific indications as to which are the situations, even of an increased nuchal translucency, where you would do any kind of gene sequencing, okay? Because if it persists, or if it's more than 5.5 millimeters, or there are associated anomalies. Because again, as for any test, you get some changes which you cannot explain. And in fetal life, because we don't have a definite phenotype, we'll never be able to say whether that particular variant is going to cause disease or not cause disease. Even if we do our sequencing, there will be differences amongst all of us. So it's important to remember that in all these tests, any difference that you find is not equal to abnormality. Many of them are equal to normal differences. We are all different, but that's because of differences in our genes, okay? So that's an important thing to understand. And it's also important to tell your patient that there is no one test that can guarantee an absolutely normal baby. So coming to our next scenario, we'll have to move fast, which is scenario 4. In this was a 4-year-old child. The child had mental retardation. The mother was pregnant. And at 11 weeks, she's referred for prenatal diagnosis of mental retardation. So she comes to the clinic. She's asked, okay, bring your first child, because that child needs to be examined. We have to identify what is causing the problem. But she says, I know my child is not okay. I am not interested in getting him tested. You just tell me whether this baby that I'm carrying, is that baby going to be normal or not? And this is a common scenario. So I would like to ask Dr. Apurva, that does a normal first trimester screen and an NT&B scan exclude the risk of any affected fetus for this family? And what is the best time that you refer these patients? And would it help the geneticists if you discussed with the family the importance of testing the affected child? And can you just offer prenatal diagnosis like this for intellectual disability directly on the fetus without testing the affected child?
Hi, ma'am. Thank you so much. Actually, I was not able to go through the initial part of the questions because I was not able to hear, and I rejoined. But yes, I have seen the scenario, and I think this is, we do get to see it more often than not. Some things that are very, very important, for us to understand is, especially with respect to intellectual disability, it's not always possible for us to understand in case if it has come from a genetic spectrum, is it falling under an autism spectrum? Was it because of any delay during the labor, or was there any meconium staining or use of instrumental delivery? A whole lot of aspects. Just because we are talking about a genetic aspect today doesn't necessarily mean that it has to be a genetic aspect. It is possible that the mother also has had any infections during the course of pregnancy, and a whole other parameters per se. But yes, unless we really have a diagnosis as to what kind of intellectual disability the first child is having, it's going to be very, very difficult for us to even screen the second child for more, or even counsel the couple for the second child.
Yeah, that's true. So within that same breath, these are the various causes it could be. And so you have to have a definite approach for the affected child. And I would ask Dr. Veronica that, sometimes we don't do tests because they are expensive, but we have this Rare Disease Day celebration. We are getting a great discount. So will you take this offer and directly test the fetus and, tell the family, well, I can make a diagnosis directly by testing the fetus and tell you whether the fetus is absolutely okay or not?
So thank you, ma'am, for the question. So when we have an affected child whose diagnosis we do not know, we can never directly test the pregnancy, and that is the rule in genetics. We need to know what disorder the fetus has before we can do a targeted testing in pregnancy. So non-targeted testing of a fetus is never recommended in pregnancy. When we have malformations, or when there is a screen positive of SG or IUDs, those conditions, we can do a testing. But if we have an affected family member, we need to make a diagnosis of that family member first. So we do not take the offer for the fetal sample at all. But for the family member, the offer, of course, can be taken, and we can do a chromosomal microarray or exome sequencing depending on the phenotype of the child. Once we assess the child in totality, take the family history, perform a deep phenotyping on the child, we decide on what sort of a genetic test he will benefit from. And once that diagnosis is clear to us, after that we can go and then test the fetus if the cause is identified to be a genetic in origin.
Absolutely. Thank you so much. And just like Dr. Apurva said, that everyone may not have a genetic cause. So it really starts from there. That could it be because of drugs? Could it be because of some intrauterine infection? Could it be some birth, asphyxia or acidosis that was not identified? And then we come to the genetic causes. So we cannot for any situation directly check the fetus. We come to our case 5. So this is a pedigree. That's how we draw it. The lady is a beta thalassemia carrier. But the key reason but her husband is fine. So we're not worried about beta thalassemia. The key reason she's come is because her first child has retinitis pigmentosa. In addition to that, so retinitis pigmentosa is a disorder because of genes. In addition to that, the child has some the development is normal, but he has some autistic features. So, what was done is that an NGS had been done for this. So gene sequencing, exome sequencing had been done for this boy. They found an autosomal dominant variant for retinitis pigmentosa with up to a 1% risk of recurrence, because the parents, actually we don't know, the testing in the parents was not done. So we don't know whether it was inherited or not. And there was another variant which was of uncertain significance for some funny disorder which had no correlation with the phenotype of the child. So Dr. Aarti, I would like to guide you. I would like to ask you, how do you guide this couple, and what procedure is to be performed, and what tests would you like to do for this couple?
For putting up this question. So we have identified the gene which was affected. It was autosomal dominant inheritance. However, since the parents seem to be unaffected with that retinitis pigmentosa, which was autosomal dominant, the risk of recurrence or the risk of inheritance, the risk of recurrence would be 1%, as you have already mentioned. It could possibly be because of the gonadal mosaicism, which would have occurred as a de novo mutation, and hence the child got affected. So the further test or the further evaluation that I would like to offer is an amniocentesis to this couple, which can pick up and do the targeted testing for this particular gene in this pregnancy.
Yeah, so you would do that once you're very certain you've done this segregation in the parents, so that bit was missing, and the geneticist has evaluated which of the two variants are relevant, and you would only do prenatal diagnosis for the relevant variant. Right. I would not do it until I'm very sure that which is this responsible for the retinitis pigmentosa, and does this variant have any clinical relevance? Yeah. So Dr. Sheetal, she comes to you in the next pregnancy for IVF. What option do they have for testing to avoid recurrence of the disease? Is Dr. Sheetal here?
So before they go for the next pregnancy, sorry, I was on mute. I would like to send them for a detailed genetic counseling before they go for the next pregnancy. And also, I think I would advise them to go for a prenatal genetic testing, because they've already had an affected child. So we don't want to repeat the same thing. So based on that, again, she has a thalassemia minor also. So for that also, we can test the embryos before we do the transplant. Putting back the embryos, I think it will make a lot of difference. And we can put only the best embryos back. So
I think that is debatable. We do not check for carrier status. Do you do that in PGT? I don't think so.
PGT-M, ma'am.
Only if there's a risk of thalassemia major for the baby, but her husband is not a carrier for thalassemia major.
Yes.
Yeah, so their PGT-M would not be indicated. And even for this retinitis pigmentosa, we have seen that the parents don't have the variant. It happened by chance in this baby. So the recurrence risk is small, but I guess if they are really keen to do a PGT-M, you could do it, but not for thalassemia and not for the second variant, which is of uncertain significance. Yeah.
Ma'am, don't you think we should offer this because the baby was affected?
But this is not correlating with autism at all.
Okay.
Okay. Just because the variant has come, we have to correlate it with the phenotype.
Okay.
So this variant is not responsible for his phenotype at all. So that is why for these specialized tests, a geneticist is very, very important. Which is the variant that is relevant and which is the variant that is not. Actually, this couple came to me, I was really disturbed after an amniocentesis. And all this had been done in the amniotic fluid of the fetus, and they were in agony because now they didn't know whether their baby was affected or not. So the aim of putting this across here is when we are doing these very specific tests and talking about the well-being of the fetus, it's important to have a geneticist or whoever has a lot of knowledge about these disorders in the loop. Yeah. So now we have a case scenario of NIPT for Dr. Mohit, and we can really go fast in it because this is something everybody is an expert in. Dr. Mohit, are you there?
I'm there.
Yeah. Hi. So this is IVF because we are dealing with a lot of IVF these days. There were triplets. There was one vanishing twin at 9 weeks. And they said, okay, I want to know my risk of having a baby with Down syndrome and I want to do an NIPT. So the lady's age is 30 years. So would you do an NIPT?
Madam, thank you for the question. Now, I would not do an NIPT for a patient with a vanishing twin in the first place. So our understanding of NIPT is that it works by examining the DNA circulating in the mother's blood. Now, most of this DNA will be the maternal DNA, but some of it will come from the placenta of the fetus. Now, in case of a vanishing twin, there is rapid necrosis of the vanishing twin, and a lot of DNA is released from the cytotrophoblast into the circulation. And this DNA will give a false positive reading. So NIPT is not indicated in case of a vanishing twin as of now.
Great. Thank you so much. That's just perfect. And the second question is that she had a high risk first trimester for which an NIPT was done. At 14 weeks, it showed triploidy. And then, of course, you follow up at 16 weeks. Triploidy means either it should have miscarried or there should be some abnormality that comes up a little later, but the fetus was absolutely fine. So you wonder what's happening and you do an amniocentesis because we have to do that to confirm any NIPT abnormality. And the fetal chromosomes are normal. So what could be the possibility and how do we explain this to the family that one test is abnormal and the second test is normal? And you also get a little history that she had breast cancer, but she went into remission about 2 years ago.
Madam, I think in this situation, the breast cancer history is of paramount importance because in women who've suffered from cancer or are suffering from cancer, especially in the advanced stages, the maternal circulation is flooded with DNA. And as a result, this can give us a false positive reading. And as a result, patients who are suffering from cancer or have suffered from cancer, this would be a category of patients we should avoid doing an IPT.
That's true. Absolutely. So we have a host of cases. And unfortunately for that woman, she actually had, by about her 8th month, she had secondaries in her spine. So that was the reason for that abnormal NIPT. And this is a host of causes for a false positive NIPT. So it remains a screening test. That's the key message here. And any abnormal NIPT must be confirmed by an invasive test. And we prefer to do amnio after a positive NIPT. And we have our last case scenario for Dr. Shrutika. Hi, Shrutika. So we have a non-consanguineous couple. She's a second gravida. And in the first pregnancy, the fetus had lots of abnormalities, polysyndactyly, polydactyly, syndactyly of the digits. There was unilateral renal agenesis. Nothing was done. They were told fetus is abnormal, bad outcome, discontinue the pregnancy. Okay, that happened. Now in this pregnancy, in the level 2 scan, some features were again seen that were related to the digits. So there was contractures of the digits of one hand, a couple of fingers were missing in the right hand, that's ectrodactyly. So again, the family was confused because they did not understand why things were happening over and over again to them. And then they opted to discontinue the pregnancy. So Shrutika, what I wanted to ask you, that as an obstetrician, you would want to talk to this family, they've come to you. And, would you think it to be of genetic in origin? What would you advise them? And they said, okay, next pregnancy, we won't do a natural conception because that's where it keeps happening. And you can test it next time, we'll do an IVF. So how would you take this forward?
Thank you, madam. First of all, let me thank you for inviting me as a panelist. It has been an enriching experience to just be a part of the panel and understand so many of the things that we don't really understand well. With regards to this kind of a scenario, as an obstetrician, I think for us, it appears like a lady who has had a second pregnancy with an abnormal fetus. So yes, genetic disorder is possible. So we have to tell them that we can't really rule out a genetic disorder. We should refer them to a geneticist, to a genetic counseling center, clinic, where appropriate tests can be advised in this present pregnancy. As an obstetrician, probably we should advise on proper testing of this pregnancy. Since the earlier pregnancy probably was missed and a proper test was not done. So maybe even doing an amniocentesis index test in this pregnancy with a chromosomal microarray, if that is what the geneticist advises, and maybe even DNA storage for any further kind of a testing, that would be indicated probably. Definitely counseling is warranted.
Great, that's excellent, Shrutika. And we know that we can't do an IVF because we don't have a definite diagnosis.
We don't have an answer presently.
Yeah. So we would do fetal autopsy and fetal testing, as you said. And this was the fetus. We did the autopsy. We found these abnormalities. And we found the abnormality in this gene, which is the LRPV4 gene, which causes Sinani lens syndactyly. This was in the era before NGS was available. So we did an autopsy, we made a diagnosis, and then we sequenced the gene and we identified the mutation. And so now you can either do a CVS, you can do PGTM, you can do anything, as long as you have this definite diagnosis for the family. And that's the key. So the messages through this panel discussion are that there are appropriate genetic tests for individual scenarios, and one jacket really doesn't fit all. So whenever we identify fetal anomalies on an antenatal scan, without a positive family history, we have to start by looking at the chromosomes. In the fetus, exome sequencing is done in very, very special situations, and it is only done under expert guidance of somebody who understands these tests. Okay, because we have to appreciate that genetic tests are not routine tests like a Holter, CT, MRI. It requires good clinical correlation. I don't interpret a Holter or a CT or an MRI. I go and take help of the experts in this, and I think we need to understand the same about genetic tests. If there is a positive family history, the affected child must be examined and appropriate tests done based on the clinical examination. And we can do pre-implantation genetic testing or prenatal diagnosis only after we have a definite genetic diagnosis in the affected person in the family. So I thank everybody for I really actually thank my panelists first for making this such an enriching panel discussion. Dr. Niharika, Dr. Narendra Malhotra, Foxy, and really the youth. I think it's fascinating to be with the youth and to be able to share a little bit of knowledge and also learn so much. Thank you so much.
Thank you so much, ma'am.
And I think
Thank
I
you
say
so much,
thank
ma'am.
you on behalf of all our panelists.
Thank you, ma'am, for this amazingly informative session. We learned a lot, carry away points from this. Thank you.
Thank you.
Thank you so much, Ratna ma'am, and thank you to all the panelists. I've really actually enjoyed today's session. I think I've myself learned so many things, and I'm going to read them again today. Thank you, ma'am. And it's been a wonderful discussion. I'll just take 2 questions from the audience because we are short on time right now. So somebody is asking how to convince a patient in doing CVS or amnio if PGTA done is normal in an IVF pregnancy.
So if PGTA has been done, there is no indication of doing an amnio unless you find an abnormality in the fetus. Yeah. But if the pregnancy is going fine, you don't need any prenatal testing.
And somebody's asking, ma'am, that where to get training for invasive prenatal procedures?
Okay. So you have the Society of Fetal Medicine. I think through the Society of Fetal Medicine, you can get training. There are many programs that do train you, but they are long-term programs, they are short-term programs, and the PCPNDT Act has specific requirements as to how many procedures you have to do along with somebody individually before you can just set up a clinic to do the procedures.
So thank you so much, Ratna ma'am. And we have our last session for today, and it's going to be all about NIPS. And
they introduce.
Niharika,
Yes.
let us introduce you. You're doing a fantastic job.
All right, go ahead.
Stella, please go ahead.
Okay. Thank you. And thank you, Dr. Niharika, for putting up such a wonderful show. Thank you, Ratna ma'am. Thank you, all the esteemed panelists, for throwing so much light on such a rare topic that we obstetricians discuss amongst ourselves. So we have Dr. Niharika Malhotra to chair this session. And I think जो एक line बोलते हैं ना कि she needs no introduction, और जो स्पीकर को वो इंट्रोड्यूस करने वाली उनको तो और भी इंट्रोडक्शन की जरूरत नहीं है, लेकिन आयरनी देखिए इंट्रोडक्शन करना जरूरी है. So Dr. Niharika Malhotra, she is the chairperson of Young Talent Promotion Committee of FOXY, consultant Rainbow IVF, and joint secretary of FOXY in 2018 she was, and now she is an active member of Aspire, ESHRI, RCOG, FOXY, ISAR, IFS, and the list is long. She has many awards to her credit, and she's adding feathers, newer feathers, colorful feathers to an already studded cap. So thank you, Dr. Niharika, and the session is all yours, and kindly introduce the most awaited session of the evening.
Thank you so much, Sheila. And it gives me great pleasure to invite my dad, but I think Rohan, I would give you this opportunity to introduce Dr. Naren Malhotra today, and let's end this session with a bang.
Niharika, I don't know how to introduce Dr. Narendra Malhotra. I don't think Sir needs any introduction. Besides his amazing achievements, I must say that I have some fond memories of Narendra uncle since childhood, especially traveling and him taking care of us, especially when we were traveling. I think he's always been a father figure to all of us in the society and always guided us so wonderfully. Just to give a quick formal introduction, Sir is the managing director of the Global Rainbow Healthcare, and he's also the past FOXY president, ISAR president, ISPAT president, IFUMB, ICMU, and he's the current president of INSAR. Sir, over to you. I won't take too much time of yours.
Thank you, children, for the wonderful words. It's indeed a pleasure to be here. And on this, and I'll be talking to you about NIPS, NIPT, NIPD, or NIFTY. Those are the terminologies used. And today we have come to a conclusion that it is NIPS which should be talking about. It's not testing, it's screening still. And it's not diagnosis, or it is not fetal trisomy testing like that. So let's see what NIPT is. I apologize for my throat and apologize for I've been out of color a little last 2 days, so but let me see if I can do gestation. So what is CFF DNA testing? Self-free fetal DNA testing. You use it for fetal sex determination. It is illegal in India. And you can use it for fetal blood group testing. You can use it for common trisomies. You can do an expanded NIPS to look at some microdeletions, and we'll see whether we can use it for single gene disorder or not. Now, when we go through the ACOG guidelines recommending NIPT, see somewhere it will be NIPT written, somewhere NIPD. So, but now everyone should address this as NIPS. So prenatal test has to be provided to all pregnant women. That's one thing. Whatever. Cell-free DNA is superior sensitivity and specificity for trisomies. If the patient is offered a prenatal test and opts to go forward, then you offer only one screening test. Double marker, EFTS, that is extended first trimester screen, or what we call as a pentamarker or a BHAPPY test, or a NIPT. You cannot do a double marker and then quad marker and then a NIPT. All these three are screening tests, only one. And when the patient gets a positive screening test out of all these three, the next is a good genetic ultrasound to rule out structural anomalies, because genetic anomalies do not say that the patient cannot have structural anomalies. A genetically normal baby could be structurally abnormal, and a genetically abnormal baby could be structurally normal. So we need to do that. And then you have to offer them a diagnostic test, which is amniocentesis chorion biopsy, which could be karyotype or microarray, depending on what it is there. So right now, cell-free DNA, current situation is an effective screening test for aneuploidies, 13, 18, 21, X and Y. X and Y not allowed in India, so it is 13, 18, 21 only. So it can just pick up risk for 3 aneuploidies. Okay, so that has to be clear. So it has to be not overused for everything. And it should be, see, whenever we do a genetic test, I'll circulate my, I did not put that flowchart, that pre-test counseling and post-test counseling is most important. Why you are doing this test, you have to tell to the patient, what if it comes positive, how are risk, and what if it comes negative. So all these have to be done. So then there are some abbreviations which we've been talking about. NGS is next generation sequencing. MPS is massive parallel sequencing. NCV is normalized chromosome. NIPT or NIPS, I've already told you, cell-free DNA. ART is assisted reproductive technology. SFAR is a selective algorithm for fetal. And CPM is confined placental mosaicism. So let's see what is NIPT. NIPT test is, as someone just also said in the beginning, is the DNA fragments which are there in the maternal blood, which have come in the maternal blood from at the time of various gestations. So abundantly released placental trophoblast, 5 to 7 weeks of gestation is started, small fragments, but not the whole chromosome. That is the problem. Had it been whole chromosome, we would have been great. Fetal and maternal DNA can be distinguished by their size because the mother DNA is always also there in the blood. So the size 143 base pieces versus 166 base pieces. That's how we make out this is fetal DNA or this is maternal DNA. And it should be at least 10 to 15% of the cell-free DNA found in the blood should be of placental or fetal origin. So what do? We can do trisomy 21, 18, 13, X and Y aneuploidies not allowed in India, and some selected micro deletions. What you have to understand, as the panel also so beautifully said, you cannot detect problems that are screened by ultrasound. So structurally abnormal babies like neural tube defect, heart defects with chromosome normal, and many other chromosomal and genetic disorders. You cannot do this. And these are various papers. I'm not going to, but you can always go through them. I'll share these slides to all of you. And all, by the way, all my slides are there on SlideShare. You can just copy them or do whatever with them. So let's see what the principle is. The cell-free DNA in the plasma of a pregnant patient is mixed with maternal and released. Then you measure it and you apply a test on it. You apply a microarray or you apply a NGS, next generation sequencing. The maternal cell-free DNA are not distinguishable from each other, but they are measured as an aggregate, and an over-representation might occur there. So when we get the cell-free DNA sample, you apply either karyotype, copy variants, microdeletion, or SNP. And the method you do it is, for an entire genome, you need to do a MPS, as I told you, massively parallel sequencing. For specific reason, you have to do chromosome selective sequencing, karyotype or microarray. And SNP you need for multiplex PCRs. So that this is how we get the DNA to multiply, amplify, and then study it. Now, who can have this test? From 10 weeks onwards, all pregnancies, singleton or twins, IVF, donor egg, surrogate pregnancies. All these can be offered NIPS. Unsuitable are those who have had organ transplant, and as we heard in the panel, cancer patients, carriers for chromosomal imbalances, those who have had transfusion by heterologous cells in the last year, and complete or partial monosomy like Turner syndrome. The test will not apply here. So how is it done? 10 ml of blood sample is taken out, sent to the lab. The lab separates the buffy coat, that the plasma in the maternal blood, puts it into a library construction in the wells, and then puts them into a sequencing machine and analyzes them. And the result comes back, and it is analyzed by the healthcare professional, the geneticist, and then it is given to you and me, and we talk to the patient about the test. So let's see now the false positives. The aberrant result may come. So false positive is very less. False negative is 0.01. Non-reportable is up to 5%. And incidental findings might be formed, like maternal neoplasias and all could be found there. So this is a normal pregnancy, and this is a T21 pregnancy. And that is how the maternal total chromosome 21, 119 in the mother, 15 with the fetal chromosome showing trisomy 21. And when you do with the sequence, the mother separately when it is a SNP. So because then you separate the buffy coat and the plasma, and you put the maternal buffy coat, order a SNP here, and you order the maternal plasmas, and then you get this reading or the DNA signatures there. The false positive NIPS can result with confined placental mosaicism, uterine demise of an aneuploid twin fetus, vanishing twin. Maternal causes could be maternal aneuploidies, mother is Turner's, maternal mosaicism, mother has 46XX and things like that. Maternal copy number variants, she has variants in her chromosomal copy numbers, subchromosomal duplications, especially mainly at 22q. And 1 point, because if you notice the reports which you've read, mostly this comes as 22q1, 1.2 microdeletion carriers, and they may be absolutely phenotypically normal. And of course, maternal neoplasms and organ transplant. Now, sometimes you get a no-call NIPS. No-call NIPS means failed NIPS. The blood collect was not good. There is very low fetal fraction because of mother being obese and others, and there's an assay failure or the machine failure. So that could be it. Then you can see the effect of maternal biology on NIPS. So mother biology will depend on the NIPS result, and that's a whole big list. Maternal weight, body mass index, fetal mosaicism, crown rump length, PAP-A, beta-HCG, pre-existing diabetes, NT, hyperthyroidism, all that has to be taken in account for a good NIPS. So let's see now, when I've told you 13, 18, 21, let's see if NIPS can be extended to beyond common trisomies. And beyond common trisomies, I mean 13, 18 to beyond 13, 18, 21. So there are a lot of studies again going on the feasibility study to see whether with NIPS we can do for thalassemia. Or we can apply the whole genome NIPS sequencerome by Illumina platform and get a whole genome chromosome wide coverage of all the anomalies. Or we can do a good sex chromosome aneuploidies. Now, because NIPS is not good for sex chromosome, the sensitivity is less. So false positive rates are there. So we improve this? And then there are some rare autosomal trisomies which are known as RATs, and they are other than 13, 18, 21. So the RATs prevalence is also there in 0.1 to 0.3, and especially trisomy 7, 15, 16, and 22. And we see a lot of 22 in our abnormalities in others. So RATs, can we extend this to RATs? And that is a challenge with the rare autosomal. Then we need to know whether we can pick up copy number variants. Now, copy number variant is NIPT is extended to detection of chromosomal deletions and duplication. So the copy of a small variant to the other variant, and that sometimes is pathognomonic. See, and they can come around
Much, Dr. Naren Malhotra, sir. And indeed, I think we've ended this program with a bang, and we had to understand that where and when to offer NIPS, because right now anything comes to us and it's like, let's do an NIPS. Offering any test, we also need to understand that it requires an extensive counseling, and that counseling has to be very, very important role in offering any genetic test to our patients. And that's why when we start planning counseling, I think all obstetricians should know a little knowledge about genetics, and that's what YTP committee is aiming at, so that we can offer them a basic counseling and then refer them to a higher center if needed for genetic tests. We have a last session with Dr. Madhulika, and Dr. Madhulika Kabra is Professor Department of Genetics from AIIMS and Delhi, and she's been working extensively in medical genetics for 25 years, and she's a box full of knowledge. Unfortunately, she could not join us right now because of a medical emergency. She sent us a small talk on overview of genetic disorders, and I'm going to be sharing her link in the chat box so that all of you can listen to this talk whenever you have time, because right now we're going to stop this webinar. We have to end this now. So everyone can go through, download this talk and listen to it. We're going to be having another session with Dr. Madhulika soon and the Department of AIIMS next month, and we'll be covering a lot more of genetic disorders. So with this, I'm going to now end today's session by thanking Thermo Fisher especially, who's now started providing carrier screening, NIPS, PGT, and CMA all over India. And they have been our collaborative partner in all genetic webinars which we have been doing under YTP. I would also like to thank Shield Connect for being with us and offering us the platform. Thank you very much. Thank you to my whole team of YTP who's here. Special thanks to all my coordinators who have worked so hard in bringing YTP to that level. And I'm sure it's going to go ahead very well. And I wish Rohan all the best ahead for his future. Thank you, everyone. And thank you to my faculty and my chairpersons. And wishing you a very